Good evening, everyone. Thank you for joining us at this extremely exciting platform of IAGES Masterclass on Ventral Hernia. We have 3 hours of an academic feast right in front of us with speakers from not only our country, experts in their own field, but also from US, the Professor Jeffrey Janis. So without wasting any time, because there will be a lot to come, let us go ahead and invite our dynamic president, Dr. Sunil Popet, who is right here with us for his address. Over to Dr. Sunil Popet, please.
Thank you, Sarfaraz. Good evening, friends. Good evening, IAGES members. I would like to compliment Sarfaraz for organizing this IAGES Masterclass on Ventral Hernia. I am joining you live from Rajmundry, where we have come yesterday to see the preparations for our next National Congress, which is going to happen in February 2022. It is my great pleasure to welcome you all this evening for this wonderful program. And Dr. Sarfaraz, Dr. John, Dr. Ramesh, Dr. Vanna, Dr. Sumit, Dr. Vivek, and Dr. Pallavi. I can see all of them, and Dr. Ashwin, all of them are here and geared up to give you the best of the feast in the field of ventral hernia. So I invite Sarfaraz to take this program forward. Thank you.
Yeah, hi. So let's begin with the first session, which consists of 3 lectures. To chair this session, I invite, and it gives me immense pleasure to invite Dr. John Thanakumar. Over to Dr. John Thanakumar to take over the proceedings, please.
Good evening. I'm John Thanakumar from Coimbatore. It's my great pleasure to invite Dr. Vivek Bindal, who is going to speak to us on inner space anatomy 2. He's the HOD of the Institute of Minimal Access Surgery, Bariatrics and Robotic Surgery at Max Super Specialty Hospital at Noida, Mohali, and Patparanj. So over to Dr. Vivek Bindal.
Good afternoon, everyone. I am Dr. Vivek Bindal, and I would like to thank IAGES, Dr. Sunil Popet, and Dr. Sarfaraz Beg for giving me this opportunity to come today and interact with you all on this important topic of abdominal wall anatomy 2.2. As we say, this is a new version of abdominal wall anatomy, which we have to learn and relearn. And Dr. Beg has very nicely called it 2.2. So I bring greetings from Institute of Minimal Access, Bariatric and Robotic Surgery, Max Hospitals. This is our case mix. We do open, laparoscopic and robotic abdominal wall reconstructions along with IPOMs and other repairs. So why we are relearning anatomy? Because of these kind of complex hernias, subcostal hernia or a paramedian laparotomy hernia, wherein our traditional techniques were not giving us good results. And that is why people across the world have been looking for newer techniques. Now for ventral hernia space, we have so many techniques in open, laparoscopic and robotic approaches, starting with anatomical repairs, Reeves, Topa, onlay mesh, anterior and posterior component separations, and IPOMs, IPOM plus, CTAP-RS, TAR, TAM, and whatnot. So today we will talk about the newer frontiers of anatomy. I've taken these pictures from the book of hernia surgery by Dr. Nowitzki. You can see these. This is a picture of abdominal wall showing the rectus abdominis muscle in between the linea alba and the lateral obliques. So the linea alba is typically 1.5 to 2 centimeter wide. The rectus abdominis on either side is on an average 7.5 centimeters wide, while the lateral muscles are there, and transversus abdominis, or the corset of the abdominal wall, has a lot of interest in today's era of complex hernia repairs. So here we can see a diagram showing a section of the abdominal wall above the arcuate line and below the arcuate line. Above the arcuate line, you can see that the posterior rectus sheath is there, which is formed by the transversus abdominis as well as the posterior lamella of internal oblique. While below the arcuate line, there is only transversus fascia and peritoneum, and the posterior rectus sheath is lacking in this place. So this is one of the important differences which all of us understand right from our anatomy days. But a new learning is that the transversus abdominis goes medial to the linea semilunaris in the upper third of abdominal wall. And this is a very important point when we talk about transversus abdominis release in these complex repairs. So this muscle is going medial to the linea semilunaris, and that is we will show in this diagram. You can see at different levels, T12, L1, L2, L3, L4, L5. As we go below, the TA retracts laterally, and in the upper part, it is coming almost till the half belly of rectus abdominis, while laterally, lower down, it retracts laterally even beyond the internal oblique. And this is an important feature which we need to remember. This is a diagram showing the blood supply of the abdominal wall, and this is showing the space of Retzius, which which we can see the Cooper's ligament, the external iliac veins and the vessels, and the lateral space and the nerves. So this is what we encounter in our traditional TEP plane, and when we do posterior component separation, we would encounter this anatomy as well. We also need to know the neurovascular anatomy, and a very important fact is that the nerves would run in between the second and the third layer of the abdominal wall. That means it is going to run between the transversus abdominis and the internal oblique. And this is a plane, a carbonyl plane where we don't want to enter, otherwise we are going to injure the neurovascular bundles. So when we do a transversus abdominis release or a posterior component separation, we put a mesh, a large piece of mesh in a sublay position. And this is a very important plane. And in this diagram, you can see how the medial edge of TA has been divided, and the mesh is placed in above the posterior rectus sheath and the transversus fascia. So this is an important learning, which gives a giant reinforcement of the visceral sac, as we used to call it, the giant prosthetic reinforcement of visceral sac. So this is seen in open surgery. The PRS is being exposed and rectus is being separated from the posterior rectus sheath. Here, this is a cadaveric dissection pic. Dr. Jignesh Gandhi invited us for a very nice cadaveric workshop he did, and you can see the posterior rectus sheath is separated off from the rectus muscle. When we divide the transversus abdominis, it looks like this. The TA muscle has been hooked, and to access the lateral space, you need to divide the transversus abdominis. And once it has been divided, you can see how the transversus fascia is being brought down and the TA muscle fibers are seen on the roof. And this is the plane where you need to enter laterally. Superiorly, you can see the diaphragmatic fibers here very beautifully. And these diaphragmatic fibers, they basically, decussate with the fibers of the transversus abdominis, and the central tendon is also seen. So you need to understand that superiorly, diaphragmatic fibers also contribute to the posterior rectus sheath, and one needs to be cognizant of this fact when they do a transversus abdominis release. This is the posterior component separation which has been done, and these are, bilateral TAR has been done. So here I am showing you how we are entering the retrorectus plane using an optical entry. And this is going to show you various layers of the abdominal wall. So we have entered the Scarpa's fascia here. And then we would encounter the anterior rectus sheath. With this optical trocar and a 0-degree scope, we are able to see the various layers. And then we encounter the muscle. Here we have come at the level of the muscle, and now we are going in between the muscle and the posterior rectus sheath. As soon as we reach this plane, we drop our hand and we make it almost parallel to the abdominal wall, so that we do not enter the peritoneum or the posterior rectus sheath. This is a potential space which we need to develop, and this is how the trocar is led into the space between the rectus muscle and the posterior rectus sheath. You can see the rectus muscle on the top, you can see the posterior rectus sheath at the bottom, and this is what you need to see. Then we would connect to pneumoperitoneum, and then we would do some kind of scope dissection to make this space a bigger one. So this is our space, and then we put in secondary trocars for enlarging the space. And then, in this space, we can see various landmarks like this arcuate line. You can see here how well the arcuate line is seen, where the posterior sheath is ending when we are going below towards the Cooper's ligament. And then we do a crossover. So here what we have done is, this is the posterior sheath. The rectus muscle fibers are seen on the roof, and the falciform ligament is seen once we have divided the PRS. So once the posterior sheath is divided, we see the falciform, we take it down, we take care not to open the peritoneum. And the idea is to open the opposite side posterior sheath. This is the opposite rectus muscle. You can see the linea alba is down, is here. So we don't want to open up here. We want to open up this area. And here we have opened the posterior sheath of the opposite side. You can see the rectus muscle fibers here, which is a very, very important, landmark to see. And you don't want to injure the linea alba, otherwise you will cause an iatrogenic hernia here if you injure the linea alba. So this is a superior crossover being done using robotic scissors and robotic fenestrated bipolar. Here we are dividing the right-sided posterior sheath and we are going on the left side. So this is the area of the falciform, wherein we are taking the falciform and the peritoneum down. And then you can see on the opposite side, there is posterior sheath. So here we have enlarged the window, and then we have opened the posterior sheath on the opposite side. And you can see the rectus muscle. So you can, you can actually go in this plane as well, which is beneath the posterior sheath. It is easy to be confused. You don't want to go into the pre-peritoneal plane. You want to come above the posterior sheath and come in between the rectus muscle and the posterior sheath. And here we are putting in a secondary trocar. After we enter, we can see, we can go intraperitoneally, we can see the hernia content, see the bowel is plastered with the previous features, but all this can be dealt in ETAP approach. So ETAP is not just totally extraperitoneal, we go intraperitoneal and we can handle these kind of bowel loops which are entering the sac without a problem. This is a volcano sign which shows the PRS on both the sides, which is divided, and the hernia content is in between. And after the contents have been reduced, the hernia defect is seen. There are multiple Swiss cheese defects in all these complex incisional hernias. So this is an image which is showing the posterior lamella of internal oblique. So here is the posterior lamella of internal oblique, and here is the transversus abdominis fibers. So once we divide the posterior lamella of internal oblique, the TA fibers are exposed. So in this area, I have divided the posterior lamella, and now I am hooking the transversus abdominis fibers using a robotic scissors and saving the NV bundle, which is laterally. So this is what we do in a transversus abdominis release. And after we have done the transversus abdominis release, the divided TA fibers are seen like this on the roof. And so this is dividing the posterior lamella of internal oblique. And then we are hooking the transversus abdominis fibers. As we are doing it top to bottom superiorly, you can find TA medially, and then as you go below, it will become aponeurotic. Here we are doing lateralization. So this is the aponeurotic part of transversus abdominis, which is being divided after reflecting the peritoneum on this side, on the other side of TA, so that we do not make any kind of buttonholes here. And we tend to keep transversalis fascia towards the peritoneum and have bare muscle on the top. Also, we need to be sure that we are saving the NV bundles. Here laterally, you can see we are going lateral, and as you go very lateral, you will find the pre-peritoneal fat giving you some more buttress on the side of the peritoneum. But here you can see the muscle was okay. Here you can see this is the muscle and these are transversalis fascia. So you need to have the muscle should be bare, and we need to have transversalis fascia towards the peritoneum. So here you can see the bare muscle, and that is what we want. This is the wrong plane. So this is the carbonyl plane. This is the TA muscle. Here we were in the right plane, and here we have gone in the wrong plane, and this is what you need to identify and then course correct. If you go into this plane, it is very easy. If you just divide the posterior lamella of internal oblique, you can easily enter this plane, but you need to just be below the TA. This is how the lateral space is created. And now with ICG fluorescence, we can also identify neurovascular bundles in a, this is a bottom-up TAR with ICG dye injected. It goes into the vasculature, and here you can see neurovascular bundles or the lamppost sign very beautifully. So here we are doing a bottom-up TAR, and this you can see is the neurovascular bundle. So we are saving this neurovascular bundle while we are dividing the transversus abdominis, switching in between the ICG view and the normal view. So ICG is going to give you some idea about the abdominal wall anatomy in complex cases. And especially in complex cases like this, here you can see the previous tags and the previous meshes. As you do more and more complex repair, we will encounter these kind of meshes, which is going to destroy the anatomy altogether. And this kind of, altered anatomy is going, this is a previous tag, which is, so you need to be conversant with these difficult anatomical situations and then deal with these kind of situations. So if you have to go from a virgin plane where you know the anatomy to the plane which has been destroyed with previous surgery, and then we need to recreate the anatomy. Recreation of anatomy without tension is the end, is the aim of this procedure, wherein you want to suture close the posterior as well as the anterior defects, and reinforce the visceral sac with a large piece of mesh. So that is how this is an artistic procedure in the hand of the surgeon. So this is how it has been done. Now, in the interest of time, I'll just say that surgery should be done to bring benefit to patient and not glory to the surgeon. And to summarize, understanding and application of abdominal anatomy has expanded significantly. Understanding of anatomy is of paramount importance to be able to do justice to the patients. And a hernia surgeon should make the best effort to learn all the procedures and apply selectively, rather than just learning some procedures and doing them on each patient they encounter. So you should know the anatomy very well. You should know the retromuscular anatomy, the intraperitoneal anatomy, and the external anatomy, and then take the right decision for the right patient. Thank you so much for your kind attention. I shall be very glad to get connected over my email or the mobile number mentioned here. And also, I would like to thank again the IAGES, Dr. Beg and Dr. Popet for giving me this opportunity.
So, thank you very much, Vivek. A very lucid and detailed talk. You've really made anatomy so easy. And it's always a pleasure to hear you every time we hear and we fall in love with you. So Vivek, I don't see any questions for you on the chat box as of now. So if you have some questions, we will we'll ask you to answer those questions. As of now, I can't see any questions. I think John wants to say something. Yes, John.
Vivek, I have a question. First of all, let me say it was an excellent lecture, but to cut short the time, you see, we know the posterior rectus sheath is made up of not only the TA, but also the posterior half, aponeurotic part of the internal oblique. So when we say we do a TA, we divide the transversus abdominis. What we are doing is not only division of TA, but also the posterior half of the internal oblique. So though we talk about just division of one muscle, it's certainly not one muscle. It's still 1.5 muscles. Is that correct or wrong?
Absolutely. Thanks, Dr. Agarwala, for the nice comments. And Dr. Thanakumar, very, very pertinent question. And I think that is something which I highlighted in the presentation also. We divide the posterior lamella of internal oblique as well as the transversus abdominis fibers. But that posterior lamella of internal oblique is divided, and then we do not do anything else to the internal oblique. One of the problems which can happen is if you just divide the posterior lamella of internal oblique and you enter in, and you do not divide the TA, you enter in the carbonyl plane, you enter in between the TA and the internal oblique, and that is a disaster. But if you are dividing both of them and then staying below the TA, you're in the right plane and you're not causing any kind of damage to the internal oblique per se. But absolutely correct, sir. So we divide posterior lamina of internal oblique along with the TA fibers.
Thank you.
So since we have no questions, I think we can go to the next speaker. So it's my pleasure to introduce our president, Dr. Sunil Popet. Basically, he needs no introduction, but a few words. He's a director and owner of Nidhi Hospitals in Ahmedabad. He's a surgeon par excellence, very academic person, an excellent organizer, and a very, very good leader and a good friend. So Sunil, I would hand over to you for your talk, adding plus to IPOM plus.
Thank you, Ramesh. Can I share my screen? Can you see my screen? Hello?
Yes, we can.
Yes, we can see it. Yeah.
Okay. Good evening, friends. First of all, I'm going to talk mainly about the laparoscopic ventral hernia repair. The most commonly done procedure is IPOM plus. And here in Rajmundry only I can see 100 PGs have joined up for this masterclass program. And I'm sure all over our platform, many PGs have joined. And so the most common laparoscopic ventral hernia repair is IPOM plus. And it started as IPOM by LeBlanc in 1992. The common etiological factors, I'll not go much in detail, but it's mainly because of the failure of the facial tissues to heal and close, what was nicely shown to you by Dr. Vivek. It's promoted by inhibition of wound healing because of several risk factors. And after every laparotomy, you have up to 20% of chance of ventral hernia, highest incidence with midline incision. And these are the risk factors which one has to be very careful. Obesity, diabetes, portal hypertension with ascites, steroids, immunosuppressive status of the patient, chronic smoker, malnutrition, and wound infection. It also depends on the type of incision. As I said, midline incision has one of the highest incidence of ventral hernia. Excessive tension, closure, and types of suture material used. So whenever we are doing a laparoscopic ventral hernia repair, we started before 15 to 20 years with laparoscopic ventral hernia in the form of IPOM, simply bridging the defect with mesh. And last 10 years, we are doing IPOM plus, where we close the defect and then put the mesh. We always give general anesthesia, and the position of the patient is supine with arms by the side of the patient. Arms are tucked in. Surgeon stands on the left side of the patient most of the time for midline and right-sided hernias. For left-side hernias, the surgeon stands on the right side. So these are the steps. General anesthesia, always put in the Ryle's tube so that the stomach is not distended. And so even if you are going into Palmer's point, you don't end up inside the stomach. So make sure that the Ryle's tube is put inside and the stomach is decompressed. Urinary catheter, we have made a protocol to put it inside and decompress the bladder. Supine position, initial access is from the Palmer's point underneath the left costal cartilage. And we put in a varus needle first, develop a pneumoperitoneum, and then go in with a Optiview trocar with a 5 millimeter telescope. And then we use 2 additional trocars, one 12 mm and one 5 mm. If there are any adhesion, we do adhesive lysis. I'm getting rebound of my voice. Can somebody close their audio, please? Then we do defect closure and then mesh insertion and fixation. So it has the advantages that it has lower rate of wound complication as compared to open repair. The recurrence rate is same and the postoperative pain are similar. However, surgeons should base the decision to perform laparoscopic ventral hernia repair on the anticipated complexity of the operation, the resources available, and the experience and the expertise. And particularly in morbidly obese, it is very helpful. and we'll hear regarding that from Sarfaraz later in the day. So I have covered this, the position and the access and the secondary ports and the adhesiolysis. So I'll go to the video to show you how we do it. So the video has started. You can see here a lot of adhesions and two defects apart from each other. And this was near the epigastric region, and this is near the umbilicus. And here it's a recurrent umbilical hernia because the previous operation was done, I think, by open technique. So we are doing adhesiolysis. We have made sure before applying any energy source that there is no bowel inside or behind the omentum. It is very important that you make sure there is no bowel. You can see the suture material, prolene of previous surgery. Then there is a lot of fat here. So we should separate this falciform ligament and take the fat away from this defect so that our mesh lies onto the muscle and not onto the fat. So one has to make sure that they take away this fatty content and falciform ligament away so that your mesh lies properly. We need 5 centimeter overlap on all the sides. Similarly, we come down to umbilicus here now, paraumbilical area, and remove this fat. So all this fat is taken away, and we have made the space. Again, this part of the fat is also being taken away. So now you can see the defect properly. So we suture close this defect with prolene material. You can also use a barbed suture material. We prefer using prolene. This is 1O prolene and round body needle. And we do complete intracorporeal suturing. Continuous sutures, and then we tie at the end. By closing the defect, you reduce the chances of seroma and the size of seroma if it does happen, and you definitely have a better repair when you close the defect and then apply the mesh. So this is a dual layer mesh. We put it inside. There were no stitch, so I put in the 2 stitches, north and south. And we actually mark it north and south. And then these are the 2 transfacial stitches we take first. We lift up the mesh and check whether it is coming nicely and covering the defects and the intervening part of the defect. So we have taken 4 transfacial stitches, north, south, east, west. And then we fix with this absorbable tackers here. Normally we do this in double crowning fashion so that the mesh is fixed properly to the muscular layer. Another case similar, but here also you can see there are 2 defects and lot of adhesions. Now this adhesions I have kept specially because you will see that the omental adhesions, we do adhesiolysis with only we can do easily with the energy source. But as soon as we see a bowel or other tissue, we go to the sharp scissors only, cold scissor. So this is all omentum. So bring down the omentum and make sure there is no bleeding. Sometimes omental vessel can bleed a lot. So behind the omentum, it was the round ligament of uterus and there was a bowel also. So we are separating it, cutting towards the peritoneum, bringing it down completely. As you can see, and this is the round ligament of uterus that was stuck there. So that is also brought down. And then we close the defect as I showed in the previous case. And put in the mesh and fix it, which will cover both the defects. Fixation to the muscles and lateral and posterior wall should be used with caution. Avoid injuries to the epigastric vessel, nerves, ureter, retroperitoneal vascular structures. Persist pain after left ventral hernia repair treated with analgesics, anti-inflammatory medications. Sometimes it requires steroids, but most of our patients have not required this. If you do come across seroma, most of this requires a watchful observation only. They don't require aspiration. Very rarely they require an aspiration. So it is important to consider this point: seroma reduction, cauterization of the hernial sac, or while you can bring the hernial sac inside while suturing, use of pressure dressings, abdominal binders, and suture closure of hernia defects. Postoperative ileus, we don't see much. Recognize intraoperative enterotomy. That is one of the most important thing. Avoid it as far as possible. If you do come across this, identify the enterotomy, close the enterotomy, do thorough washout, and abandon the hernia repair. You can always come back later on. If you find out delayed enterotomy, then obviously it will require emergency laparoscopy, and if may require laparotomy, closure of the bowel. And if there is a soiling of the mesh, you need to remove the mesh also. And you can come back for hernia repair later on. So mesh infection and antibiotics are also one of the complications. I think we'll hear regarding that in the later part of the program today. The advantages are there is less excess trauma, smaller scars, better cosmesis, less soft tissue dissection, very good view of the hernia and Swiss cheese defects, decreased wound complications, and less morbidity. One more thing here is sometimes we do see ventral hernia with rectal divarication, and as I showed the suturing of the defect, similarly we suture the rectal divarication, bring together the posterior sheath and close that. We do the plication of the rectal divarication and put in a mesh. I'll not discuss mesh infection here. So place all the ports as far away as possible from the defect. Switch scope position as necessary. Keep intra-abdominal pressure high during the dissection and low during mesh fixation. And very importantly, handle the mesh properly. Thank you very much for your patient listening.
Thank you, Sunil. Thank you, Mr. President. That was an excellent talk. As always, you have done more than enough justice to the topic. And you have not only given the indications, but also the complications of the procedure in addition to the video picture of the entire procedure. Time for questions. I'll start the ball rolling first. I just want to ask you, we know you're a very distinguished intracorporeal surgeon and you can do any kind of suture. But for those people who are watching who may not be that good on intracorporeal suturing, first of all, I agree, they should know how to do intracorporeal suturing before they enter the ventral hernia repair. There is a way of making a small nick from the outside and put in the needle through a port closure needle. And then we want to say a few words about that, just for people who may not be very good at or comfortable in intracorporeal suture.
Yeah, thank you, John. I have seen some people doing that. They put in the needle through the anti-abdominal wall in the site of the hernia. Well, you can do that if you're not comfortable, but I am always worried about putting a puncture on the anti-abdominal wall just anterior to the hernial defect, because that skin is little bit thinned out. And if you have larger hernia, it would be thinned out much. Second thing, your mesh is just going to lie there, just underneath the muscular layer. So I would prefer to avoid puncturing the skin of the anti-abdominal wall. I would rather go through my port, and my central port, which houses the camera through which my mesh is going, is 12 mm port. So the needle can go out easily and come out easily.
Thank you. Since the topic is on plus, I want to ask you one more question. What's the minimum diameter for which you would recommend a plus? And what's the maximum beyond which you say, no, I'm not doing a plus, I'm giving up the procedure?
So our understanding is 7 centimeter is the limit. And even though 7 centimeter defect size, sometimes we find it very difficult to oppose the muscles together. So this cases will not go for IPOM plus. But to do it comfortably, I think up to 6 centimeter is quite fine. However, the evidence suggests that 8 centimeter up to 8 centimeter transverse defect, you can mobilize and close it nicely and put in a mesh. But I think it's all, while you are closing, you are always watching that how much tension you are giving to the tissues.
Do you have any minimum, or you suture all your ventral hernias, even smaller ones, less than a centimeter? You have a minimum?
Less than 2 centimeter, we don't suture.
Thank you.
Yeah.
I think we're sort of running short of time, so we'll go on to the next speaker.
Thank you.
Thank
you, John.
Thank you. Dr. Vandana Soni. It's always a pleasure to listen to Dr. Vandana. She's the director at Max Super Specialty Hospital, Gurgaon, Delhi. And we know for decades, excellent speaker. She's very fluent on various other things like thoracoscopy, VATS and all. But today it's a pleasure to listen to her speak on RIF hernia, my approach. Vandana.
Good evening, everyone. It's a pleasure to be part of this IAGES Hernia Masterclass, talking about a subject of keen interest. This is my case disclosure. Approximately 23% of the surgical procedures being performed at our center comprise hernia repairs, and of these, barring the groin hernias, hernias in the right iliac fossa account for less than 1% of all hernias. This presentation, there is no conflict of interest. So what is the right iliac fossa? This corresponds to a depression in the iliac bone bound superiorly by the iliac crest and the arcuate line below, and the fossa in which the iliacus muscle arises. The surface marking corresponds to the right inguinal region. A hernia in the right iliac fossa may be primary, which includes the direct and indirect inguinal hernias, the femoral hernia, Spagilian hernias, and atypical ventral hernias like para and periinguinal hernias. Or it may be incisional, following an appendectomy, and the lateral edge of a fan and steel incision, ureterolithotomy, as well as parastomal hernias. However, for discussion today, I'm only going to talk about Spagilian and maybe atypical ventral hernias in the primary hernia group, and incisional hernias following an appendectomy, and lateral edge of the phalansteal incision. Now, a word about Spagilian hernia. This arises in the Spigel's aponeurosis, also known as the linea semilunaris, which was described by an anatomist by the name of Adrian van der Spiegel in the 17th century. However, a hernia through this aponeurosis was first described by Klinkorsch in the 18th century. The reported incidence of Spagilian hernia is 0.12%. The Spagilian hernia occurs most commonly at the semicircular line or the arcuate line of Douglas. The fascia of the oblique and transversus muscles start to split at this point to allow formation of two separate layers, and thus this is the juncture which marks the weakest point in the aponeurosis. Spagilian hernias are difficult to diagnose unless they are symptomatic, because most of them are interparietal, and the giveaway or the hernial defect is primarily involving the transversus and the internal oblique aponeurosis, with the external aponeurosis being intact. The incidence is higher in the 4th to 7th decade of life, seen more often in women, more left-sided than right, and about 2% of these are discovered incidentally while performing laparoscopy for some other indication. The clinical importance of Spagilian hernias is the risk of incarceration, which is increased in patients with a high BMI, in women, and especially those aged more than 50 years. Nearly 25% of Spagilian hernias are operated as emergency cases due to incarceration. Now, Spagilian hernias should classically be diagnosed on clinical examination, especially if all three aponeuroses or the aponeurosis of all three muscles are involved. However, in the absence of an obvious bulge or a cuff impulse, a CT scan and an ultrasound are the recommended diagnostic modalities. On the other hand, let's talk about incisional hernias. The occurrence of incisional hernia following an appendectomy through a McBurney's incision is very low, to the point of 0.12%, and incisional hernias following a caesarean section in a phalansteal incision has been reported to be between 0 to 5.6%. So what is the significance of hernias of the right iliac fossa? First, it's a difficult location. Part of the wall is formed by the bony ilium, and anteriorly we have the groin area, which is the junction between the preperitoneum and the retroperitoneum, containing a lot of important structures there and causing a difficulty in distal fixation. There is a lack of inadequate space to allow adequate mesh overlap. Treatment of hernias, as we all understand and accept, is surgical repair. For hernias in the right iliac fossa, the options can be both open and laparoscopic. In fact, even following open suture repair, the incidence of recurrence is pretty low. However, it is recommended now that a mesh be used for repairing these hernias. Today, I'm going to primarily discuss laparoscopic repair of right iliac fossa hernias, because this is the approach which I primarily like to adopt and have an experience in. So what are the laparoscopic surgical options we have? The first is the tape, which is the commonest, easiest to perform, and provides a very good repair. This is transabdominal partial extraperitoneal repair. The other is TP, possible in small defects, lower lying defects, in fact more for para and periinguinal hernias. That is the total extraperitoneal repair. The same for those who are more comfortable performing the TAPP. The same hernias can also be handled by this approach. So the principles of the partial extraperitoneal transabdominal repair are: first, creating the extraperitoneal space distal or below the lower edge of the hernial defect by incising the peritoneum. creating a large enough flap to identify the psoas inferiorly, inferolaterally, and the Cooper's ligament and inguinal ligament, Cooper's ligament and the pubic arch medially. Fixation of the lower margin of the mesh to the Cooper's ligament. Laterally, the inferior margin of the mesh should lie comfortably on the psoas, and then closure of the peritoneal flaps. So this is a short video showing a hernia following an appendectomy. So an incision in the peritoneum is given well beyond 5 centimeters superiorly and extended inferiorly towards the midline. The flap is raised further. Medially, the pubic bone and the Cooper's ligament is identified. The round ligament clipped and divided. The psoas, the pubic bone, the Cooper's ligament medially, psoas extending superiorly laterally, and then an adequate size mesh is placed, fixed superiorly with transfascial sutures, and then fixed inferomedially to the pubic bone. The lower margin or the remaining lower margin of the mesh, which is unfixed, is closed or put retroperitoneally with a peritoneal flap. However, additionally, closure of the fascial defect, which is now accepted during incisional ventral hernia repair or during Spagilian hernia repair, will reduce the rate of seroma formation as well as adverse hernia site events. Therefore, this is a brief video showing the same. As you can see, this is a recurrent incisional hernia following an IPOM repair of a primary Spagilian hernia. Now, once adhesiolysis has been performed, the peritoneal flap is raised below the inferior margin of the defect. The defect is closed by after freshening the edges with a port closure needle using polypropylene, and then taking transfascial sutures, the mesh is fixed with at least 2 points with the transfascial sutures, and then the lower edge is reperitonized, and proximally with partial fixation devices like ProTag, the mesh kits, is placed in position. For extraperitoneal technique, the classic access through an infraumbilical opposite side incision is made. The space is created with an indigenous glove finger balloon. The midline working ports are placed. Standard exposure is performed of the myopectineal orifice. The Spagilian hernia sac is identified, dissected and reduced. The peritoneum is stripped further superiorly to provide space for an adequate mesh overlap. The mesh is placed and fixed inferiorly to the pubic symphysis and Cooper's ligament and superiorly to the transversus abdominis sheath. This is again a brief video of the same. As you can see that there we have already created and entered the preperitoneal space, that is the pubic bone in the midline distally, and we proceed laterally, having dissected the space of retius, that's the Cooper's ligament. We open the space of Bogro's. The peritoneum is stripped down and the cord structures are exposed. The peritoneum is further stripped off proximally, and this is the site at the level of the lateral edge of the arcuate line of Douglas that one is able to identify the Spagilian sac and the defect. So that is the defect. It's a classic interparietal hernia, but primarily contained preperitoneal fat. The peritoneum is further stripped proximally to provide space for mesh overlap. And once satisfied, a standard 15 by 12 centimeter polypropylene mesh is used to cover not only the myopectineal orifice but also this small Spagilian hernia. So as you can see, the mesh will cover both the hernial defect and the myopectineal orifice adequately. So according to the International Endohernia Society guidelines that were first published in 2014, a level 2B evidence statement stated that the laparoscopic repair was superior to the open repair because of reduced morbidity rates as well as reduced length of hospital stay. And the placement of a mesh was preferred either whatever the method of approach, whether laparoscopic or open, although the level of evidence was 4. Recommendation was that the mesh should be used to repair these hernias and that a laparoscopic repair should be preferred. The updated guidelines published by IAGES in 2019 again endorsed the statement which was made in the 2014 guidelines. In addition, they also made a statement that whether doing an IPOM or a laparoendoscopic approach, the results were comparable. Again, the recommendation stood the same, that preferably they should be repaired using a laparoendoscopic approach and a mesh to reinforce the closure. The European Hernia Society and American Hernia Society guidelines collaborative effort had addressed two key questions. The results were published in 2020. The first was to identify which is the best diagnostic modality, and the recommendation was, of course, that primarily it should be a clinical diagnosis, but barring an obvious clinical finding, one could perform an ultrasound or a CT scan for diagnosing these hernias. And the preferred method, they also suggested that whether doing an open or a laparoscopic repair, a mesh should be used. So to conclude, hernias in the right iliac fossa are lateral hernias. They are complex hernias. A distal peritoneal flap should be raised to provide adequate mesh overlap and fixation. The laparoscopic approach reduces morbidity and hospital stay, and closing the defect before mesh placement decreases seroma formation, bulging, and other hernial site occurrences. I thank you for your patience. Open to questions.
Thank you very much, Vandana. A very lucid presentation. You've dealt it so well. These are not very common hernias. And often, people who are beginners, they have difficulty of finding how to get that distal space for the overlap. And you rightly showed all the three approaches, how they can be dealt. So it's a very good presentation. Thank you very much. I do not see any questions in the chat box for you, Vandana, as of now. So later on, if we have some, we will call upon you to answer those. So now over to Sarfraz. We can go on with the next speaker, Sarfraz.
Yeah. Hi, yes, please, Dr. John.
Thank you. I think next speaker is going to be small change. Is Dr. Sunil?
No, Dr. John. No, Dr. John. Professor Janis is here now. He's here now.
Okay.
Professor Janis is here. Yeah. So, hi, Dr. Jeffrey. Can we see you here? Yes, we can.
Just logged on. How are you doing?
We're doing fine. So good morning
Good morning.
So it is your good morning. It's good evening from here, but I guess it's all right. You do look as if you are going to enjoy your entire day. You're well suited for the entire day. And it's
at least above the waist. This is rare for me to wear anything besides scrubs. So here you go.
Right.
Welcome to Zoom.
Yeah, welcome. Thank you so much. So we are very honored to have you here. We have the president of IAGES, Professor Sunil Popet here.
Welcome, Jeffrey. Welcome.
Thank you.
And we have our ex-president, Dr. Ramesh Agarwal as well here, Dr. John Thanakumar. Yeah. And plenty of other luminaries who are also here. And it's a pleasure and honor to have Professor Jeffrey Janis with us. When I asked Jeffrey to give me a CV, I received 180 pages of CV, and I realized that I am up for a big task. And he was he was kind enough to send me a smaller one, and I picked it up. And I would like to introduce, it's really an honor to introduce Professor Jeffrey Janis. I must say that I've been reading his papers for quite some time now, and I'm going to probably have the privilege of asking him some questions after his talk. But let me introduce for everyone Professor Jeffrey Janis. He's a full-time faculty as a professor in the Department of Plastic Surgery at the Ohio State University, Wexner Medical Center in Columbus, Ohio. He is also Chief of Plastic Surgery at University Hospital, co-director of the Center for Abdominal Core Health, and holds adjunct appointments as a professor of neurosurgery, neurology, and surgery. He is a past president of the American Society of Plastic Surgeons, the American Council of Academic Plastic Surgeons, and the Columbus Medical Association, and currently serves as the president of the Migraine Surgery Society. He is the president-elect of the America's Hernia Society and a governor on the Board of Governors for the American College of Surgeons. He is also a member of ACGME's Plastic Surgery Residency Review Committee and serves on the EC for the Surgical Pain Congress, as well as the Executive Committee for the Ohio Valley Society of Plastic Surgeons. He was recently appointed as the editor-in-chief of the Journal of Plastic and Reconstructive Surgery, Global Open. To date, he has served as a visiting professor at 48 major national and international institutions, published nearly 200 peer-reviewed articles, 109 book chapters, and 6 books, with 3 more books and an app pending publication, and has given nearly 950 lectures. He was also a part of the team that performed the first full US face transplant at the Brigham and Women's Hospital in Boston, Massachusetts. Dr. Janis was named Clinician of the Year in 2004 from the Department of Plastic Surgery at UT Southwestern, Teacher of the Year in 2008 and 2013, and received Special Achievement Awards in 2007 and 13 for outstanding contributions and dedication to advances in plastic surgery resident education. His published work has been cited close to 10,000 times as per Google Scholar. Ladies and gentlemen, allow me the honor of introducing Professor Jeffrey E. Janis. So Jeffrey, thank you very much for joining us. We will put your talk right now, your recorded talk right now, but do stay around with us for the Q&A. Plenty of people would like to ask you plenty of questions.
Well, I certainly appreciate the honor and privilege of talking to you today about why and when we need plastic surgeons in hernia repair, and what does a general surgeon need to know about the advantages of a multidisciplinary collaboration across specialties between plastic surgery and general surgery. With that, I will tell you, that's what people came to hear as the talk.
Perfect. Let's go on.
Well, I certainly appreciate the honor and privilege of talking to you today about why and when we need plastic surgeons in hernia repair, and what does a general surgeon need to know about the advantages of a multidisciplinary collaboration across specialties between plastic surgery and general surgery. With that, I will tell you I have no disclosures that will impact this talk. And where appropriate, I will certainly add all of my peer-reviewed references at the bottom of each slide. We have certain objectives we're hoping to cover today in this talk, which is what are the roles of these disciplines, general and plastic surgery. Let's review some techniques that will help decrease complication rates. And in particular, we will also focus on soft tissue management in order to obtain optimal results. Here are some photographs from my clinical practice. I'm sure all of us have a series of photographs that march through our offices every week. But obviously, we have infected mesh and skin ulcerations, some tenuous skin coverage, intercutaneous fistula, some domain issues, multiple wounds with exposed mesh, maybe the off midline ventral hernia, the ever-present ostomy. Morbid obesity is a significant problem no matter what country in the world you're from or what state you're in. There can be histories of trauma. There are high-risk patients. The only way not to get complications is not to operate. And so certainly we all see secondary complications that come to our attention. And some of these patients look pretty straightforward. They're not necessarily obese or overweight. They're fairly simple, maybe first-time hernias. There are other patients that seem to be simple, but are not quite so simple, like this 4-time recurrent umbilical hernia with a previous history of infected mesh. Nonetheless, some of these patients can be solved with just straightforward general surgery. Others require the addition of other disciplines such as plastic surgery. And that's where these types of patients come into play, where you start to see some of these unfavorable abdomens that you say, you know, maybe this is beyond the scope of what I'm used to or my expertise or perhaps my training. And you start to say, okay, is this the tip of the iceberg? What happens when I dig out this infected mesh? And especially if there's a paucity of soft tissue, or there's multiple wounds or multiple scars from previous operations, or in some cases, it's not the obesity of the patient that's the problem, it's how big the hernia is or how big the soft tissue defect is relative to the patient's size, such as these patients. So again, we have a myriad of patients that come across our attention, and how do we solve these problems when you see these patients? When do you get a plastic surgeon involved? Under what circumstances? And most importantly, for what reasons? So the tips that I would summarize for general surgeons are around management of skin, and in particular, excising redundant skin or even creating additional skin, avoiding T-incisions, using negative pressure, and we'll also see how to manage skin and get better results. So I divided this up into kind of categories. The first one will be what happens when you get too much skin. Now, these types of patients, the ridiculous panniculus, if you will, these are actually different patients that you see here, even though they morphologically look the same. That's really an entire separate lecture. So I'm really going to discard that. And if you want, we can talk about that at a different opportunity. But all of us see patients that are obese, and at least in the United States, we're seeing a skyrocketing of BMI over time. If you look at maybe our color Doppler radar map of what the average BMI used to be back a few decades ago versus what it is now, it is far different. And unfortunately, that's a trend that is continuing in the wrong direction. Currently, over 40% of the US adult population is actually obese. This affects not only adults, but this affects children. And by the end of this year, 3/4 will be either overweight or obese. And so that is certainly an award that the United States does not want to win. If you go back in time and look at the 1950s, all of us are about 26 pounds heavier than we used to be, and there's significant cost to this in addition to how it affects our activities of daily living. This is not just a United States problem. Clearly, this is a problem across the world. Although the United States certainly is #1 on this list, you can see other countries are still struggling with the same situation. And why does this impact hernia repair? Because as Todd Henneford and others have shown us, morbid obesity does increase risk for hernia formation. That's why we need to optimize BMI both before and actually recent evidence shows after surgery, because that lends to the durability of the repair. We can get into some discussion maybe at the Q&A session about how much is too much to weigh before one considers elective surgery, let's say in the asymptomatic patient. Now, we do derive important literature from other specialties. And so when it comes to what we learn from cardiothoracic literature, for instance, we do know, and you're probably wondering at this point, why am I showing you pictures of patients with symptomatic hypermastia or large breasts that are candidates for breast reconstruction? But we do learn from a couple of papers from the early 1990s from cardiothoracic literature that if you do median sternotomies on patients who have gigantomastia, that you have statistically significant increases in the risk of dehiscence of the median sternotomy. And you actually advocate for concomitant breast reduction, even in the face of median sternotomy, because you get decreased wound healing complication rates. And so these are some of my patients that I'm showing you here. And even though this patient is a breast reduction patient, the reference line along the sternal midline, you can see, imagine if she was a median sternotomy patient, you easily can appreciate the lateralized distracting forces that large breasts will put on to a median sternotomy, leading to increased complication rates. So why does this pertain germane to the talk that we have today? Well, because obesity is so prevalent everywhere across the country and across the world, you basically have heavy, weighty, redundant tissue that is acting as a lateralized distracting force that can lead to complication rates such as wound dehiscence. So one way to deal with that is by, in the patient who has too much skin, is by removing that extra skin. Now, if you look at males and females, it doesn't matter. You see that most patients carry their lipodystrophy in the inferior third. And when we're designing excisional patterns for redundant skin excision, most of us, at least, and including myself, have been historically excising this as an ellipse. The problem is that geometrically an ellipse means that you're trying to excise the most tissue in the middle third, but most patients are carrying their redundancy in the inferior third. So if you just adjust the pattern to be more of a teardrop shape instead of an ellipse, then you're actually excising the redundancy where the redundancy exists, and that gives you a much better result. This is where I didn't do it in this patient with a 2-year follow-up. And if I had to do this patient again, you can see that I left redundant tissue behind. You can especially see that on the lateral view. And so if I had to do this again, I would not excise as an ellipse. I'd excise as a teardrop. The other thing is we can always tell even on CT scan preoperatively that due to domain loss, the anterior surface of the hernia sac oftentimes approaches the subdermal level. And after reduction of the hernia, what you're left with is this very tenuous soft tissue, essentially based on subdermal plexus, which is not a robust blood supply, as you well know. Leaving this behind without excision is going to lead to higher complication rates. So we do want to resect marginal skin tissue and soft tissue behind and not leave it there where it is prone to complications. How do I do this? I use my second favorite instrument, which is the piercing towel clamp. And there are many ways to do it. This is one. You can use these penetrating or piercing towel clamps to suspend the redundant skin, and therefore you can excise that and then close that in a complex layered fashion. Now, we don't want to over resect. So one way of doing this is what Al Ali describes as the double crown technique. Now, he's using that technique for body contouring after massive weight loss. For instance, this image taken from his book on your left is from a brachioplasty, or essentially an arm lift. And so in this situation, we want to pinch the skin, but we don't want to over resect. So how do we accommodate and make that more safe? We basically measure the diameter between the pinch, we divide it by 2, and we add it back to the pinch. So if you have, let's say, 4 centimeters of pinch in between the two, then you'll divide that in half and you'll pinch in by that much. And that's why you have a double crown technique, because you're adding skin back so you don't over resect. So another technique that we want to use is when we resect this redundant tissue here suspended by these piercing towel clamps, we don't want to use electric cautery, because that will create a penumbra of thermal damage, much like a burn, and just lead to increased complication rates with respect to skin closure. So we make our skin incision with the knife, and then we can use electric cautery to complete the resection. And that is going to be a much more favorable outcome than just turning your electric cautery up to arc weld and basically burning the skin. So we do have to be mindful of some of these small things that matter, because like anything else up to and including marriage, it's the small things that turn into big things if you don't solve them when they're small. So here you're going to resect the redundant skin and subcutaneous tissue. After the resection, you have little undermined tissue and you go ahead and close. Now, this is another method of removing extra skin that's redundant. This is called Tailor Tacking. We use this all the time in plastic surgery. And again, what you're doing here is imbricating the redundant tissue between a pair of forceps, and you're getting that haptic feedback about how much redundancy is too much redundancy, so you can cheat back and add soft tissue back before resection. So again, you've got a line of safety. After you've done your staples, you use an indelible marker in order to describe what will be a customized resection pattern. And then afterwards, you remove the staples. And essentially, after you remove the staples, you're getting exactly where you should cut. So I'll fast forward here, and you see exactly what we're anticipating on resecting on your left and what we've resected on the right. And then afterwards, if there is any undermining left behind, then we'll do either progressive tension sutures or quilting sutures. These are 2O rapidly absorbable suture, like 2O Vicryl. And we're locking down this skin flap because Mike Liang showed us that undermined skin flaps can have complications if there's too much undermining. And so that's why we take a little bit of extra time to do this. Also decreases seroma rates, which again is a separate lecture that we could talk about a different time. Another method is with this finger imbrication. So, I'm just trying to show you multiple methods about how to deal with redundant skin. And as plastic surgeons, we deal with this all the time. So in this case, after pinching this together and again, using haptic feedback about how much is too much, we'll go ahead and draw with an indelible marker our resection pattern. We'll line up the closure. So this is what the patient sees. We need to have meticulous attention to this, and we do a complex layered closure. Now, one thing we want to avoid are these T incisions. I downloaded the picture on the left from the internet. The picture on the right is a picture of my own patient, which obviously has had a complication right at the intersection point of the vertical incision and the transverse incision. So how do we avoid these types of complications? One way of doing this is what's called a Mercedes closure, because the closure resembles a Mercedes sign. This was described by Chuck Butler from MD Anderson. And essentially what we're doing is raising the confluence point to the mid-abdomen instead of the low abdomen. And that accomplishes many things. First of all, this confluence point is not a right angle, but instead these are oblique angles here that basically give less tension on the incision and not the right angles that can contribute to necrosis, especially of the skin tips. The second thing here is that you've now got this inferior skin flap, which actually is supplied by axial blood supply, specifically the superficial inferior epigastric arteries, both sides. And so now you have axial blood flow that provide better, robust blood supply, so you have decreased complication rates. The third advantage is that this incision, if it were to break down, is not in the least hygienic portion of the abdomen like it otherwise would be. So when I do this, I actually call this a predator paniculectomy. This is an American movie, obviously, that when I saw it, it just reminded me of this. And I'll show you that this is a patient who was overweight, obese. She actually lost through diet, exercise, and lifestyle modifications her weight without the need for surgical intervention like a bypass. But here you can see when I saw this and did this in the operating room, just reminded me of this movie. So I call this a predator paniculectomy rather than a Mercedes paniculectomy. And she got closed afterwards, incisional negative pressure wound therapy, and everything looks good. So now let's shift gears to what happens if there's too little skin. This is an example of a patient of mine who had some gunshot wound trauma in the past. Obviously, he's got a physically fit, fairly athletic appearance here, but he's got a wide hernia and he's got an upside down U here instead of an upside down V at the point in the abdomen where it's most difficult to close. So we have to predict these complications before they happen. We clearly don't have enough local regional tissue natively to just go ahead and close this after hernia reduction. So what do? We're going to go ahead and pre-plan for that by placing tissue expanders, or essentially surgical water balloons, below the skin. We're going to inflate them in our clinic over time, which will generate more skin. And later, when we do the hernia reduction, we will remove these surgical water balloons after creating this redundancy and use this redundancy to our advantage to get more stable soft tissue closure. This is a 1-month follow-up, and I'm just showing you here on purpose the worst picture I could show you because it's an early follow-up. You still see that the incision here is still tenuous. It goes on to heal quite well. But even in the face of an ostomy takedown and a large ventral hernia repair, you still have good, stable soft tissue closure, and that would not have happened if we didn't plan for it in advance. Here's another gentleman, actually a similar situation. We knew we were going to have a paucity of soft tissue. Using plastic surgery expertise, we pre-placed 2 large crescentic tissue expanders and actually lost 1 to infection here. And believe it or not, this guy disappeared for 7 years. And when he came back, this tissue expander was still intact. Now, why he waited 7 years to come back, that is a story for a different time. I actually don't even have a good answer for you. But clearly, this was mature, the skin was expanded, and now we could go back to the operating room, take off the skin graft, lyse the adhesions, perform our repair, And we had generated more soft tissue by removing this tissue expander. You can see here, this capsule that had been left behind over time had even calcified, and I'm showing you that here in the picture on the left. So we actually had to do a capsulectomy in order to get better tissue compliance, to get our gold standard midline musculofascial reapproximation. In this case, we've already done now an open component separation because the skin flap's already been undermined by the expander, and we go ahead and place our mesh. We get the midline eventually closed, and then we here have this scar tissue on the right side, which we were concerned about. And if you are concerned about it, you can use intraoperative indocyanine green angiography in order to evaluate whether you think that's going to live or not. And then ultimately, we left that in place because we got good signs from it, and he goes on to heal quite well. Here's another example. Again, not enough soft tissue. We've got a fairly wide hernia. We predict we're going to be soft tissue short using plastic surgery expertise, pre-planning, and some technique and technology at our disposal. We'll go ahead and pre-place crescentic tissue expanders. Then we'll go ahead and put in this case was a double lay. It was an underlay and an overlay of non-cross-linked porcine acellular dermal matrix. We go ahead and close, and we're able to get primary reapproximation. Final person was a crane lift operator that I had met originally in Texas, followed me to Ohio. He had 64 prior abdominal operations from multiple. It was an original gunshot wound with some significant complications, obviously physically fit. Again, I predict we're going to have some coverage issues due to prior scar, both in the midline and on the lateral side. So we're going to pre-place abdominal tissue expanders, which you can see here. We're going to close the incisions. We're going to bring them back to clinic, and we're going to inflate that through this remote port. And then after clinical tissue expansion, you can see here that we've generated more soft tissue that we will eventually use. And now we have an anterior component separation that we're about to perform because we've already undermined the soft tissue with the tissue expanders. You've got this nice, rich, vascularized capsule that we're going to use to our advantage. We take out the tissue expanders, and this is how we do the operation here. I'm just showing you a quick movie, to make it more clear. Again, I wouldn't normally perform a widely undermined anterior component separation with this much undermining of the skin flap, but we've already placed that tissue expander in between the skin flap and the underlying muscle, essentially a delay, plus we get the vascularity of the capsule, which will help us out. And in this case, we'll palpate the semilunar line, and then about 1.5 to 2 centimeters lateral to that will create our external oblique aponeurotomy. This is not a willy-nilly relaxing incision. This is an anatomically precise external oblique aponeurotomy. You can take this down to the inguinal ligament inferiorly, and superiorly, you can take this up above the subcostal margin. Of course, there's more muscle there superiorly because we know that from our anatomy. I'm using a non-conducting plastic Yankar suction tip to assist here. And then after we perform our external oblique aponeurotomy, we will take the time to delaminate the external from the internal oblique. You can take this back as far as you need, anterior axillary line, mid-axillary line. You could take it down to the posterior axillary line. And then at the end, you can see the type of release that we get. And we go on and get him closed. And again, that's due to pre-planning and plastic surgery expertise. And I'll show you here, this guy goes on to do MMA. So this guy is, it's amazing how with function, he goes back and does mixed martial arts. And that's what he does now at the pseudo-professional level. The last thing here is what happens now that we've looked at too much skin, too little skin. How about if you don't know how to manage the skin? Again, we have patients, multiple scars, multiple operations, this ridiculous paniculus I talked about. Some of the adjunctive techniques we can use, for instance, this, I call it the string of pearl French fry approach. We know in some cases we have up to a 100% risk of incisional complications. So why don't we control that rather than let it control us? So this is essentially almost like a delayed primary closure, but we're controlling it. In these situations, after removal of the pedunculus, we're doing intermittent primary closure. That's the string, but we're purposefully leaving open some portions of the incision. That's the pearl. And through that, we're putting in these vertical struts of polyurethane foam sponge and then a crossbar overlay. And in essence, it'll act not only as a drain, because it'll remove what otherwise would certainly become a seroma, but it allows us a delayed primary closure. And in this case, you can see it goes on to heal quite well. You would never know that even occurred. We've described this in book chapters and other publications, but you can see here another patient where we're using a silver foam sponge, and you can see that I've left some of the opening some of the incision purposefully open. We take this foam sponge and we cut it into crossbars and vertical struts. And then I'll show you again here a quick movie that we can insert these vertical struts into the openings. Otherwise, I call, again, the pearls. And then once those are in, then we can use some Xeroform to cover the closed portion of the incisions. And we can use a crossbar on top of the vertical struts, which will allow us to transmit the negative pressure down through those vertical struts. And then we'll go ahead and close. And this will be a controlled incision closure rather than a potential complication. I have no conflicts of interest to speak of, just so you know. I already documented that at the beginning of this talk, but incisional negative pressure wound therapy is a useful technological adjunct, basically improves blood flow to improve wound healing, decreases tension and acts like a splint. And actually it improves lymphatic clearance, not by removing fluid through the closed incision, but actually it's got a 50% improved lymphatic clearance when you look at radio-labeled isotope lymphocytes. So it improves lymphatic clearance. This publication, published in Hernia in 2017, shows that when you leave this on the incision in hernia patients for 5 days or more, you get statistically significant improvement in complication rates and less interventions. And again, that's a good p-value there. This meta-analysis by Devinder Singh shows the same thing, basically statistically significant decreases in wound healing complication rates, and actually a cost savings when you use it in appropriate patients. And by that, I mean patients that are expected to have an incisional risk greater than 16%. So if you were using ventral hernia working group grade 2 and above, or Cantor's grade 2 and above, that's basically when you're going to use that. If you want to see more information, we wrote some articles on this, including this one published in Hernia in 2017. And then finally, if you need help, I work also with our surgical oncologist. This patient had a desmoid tumor. After resection, I walked into the operating room. There's basically a hemi-abdominal composite defect. This is something that usually general surgeons are not typically seeing or reconstructing. And so that's where the utility of a plastic surgeon comes in. We're going to do a combined composite repair here. We're going to divide the defect up into subcomponents. Here we'll use an ALT or anterior lateral thigh flap. We'll use a non-cross-linked porcine acellular dermal matrix, circumrib sutures, bone anchors, and soft tissue coverage. And then here you see basically long-term follow-up. And this patient, which is a patient of a colleague of mine, Mike St. Cyr, who's now out in Arizona, you can see that, again, you can combine these techniques. You can pre-expand what will be a deep inferior epigastric artery perforator flap with a tissue expander like I just showed you. And then you can do a propeller flap transposition, and you can close so that you can close these defects with good, healthy autologous tissue. And again, mandating the multidisciplinary approach between a general surgeon and plastic surgeon. And so with that, I just want to thank you. I think we're right on time in terms of the time allocated. Hopefully, as a result of this talk, we've been able to see why one would need a plastic surgeon, especially in some of these complex patients, what the utility is. both with respect to too much skin and too little skin, and also some of these complications that can occur in patients who have had multiple previous operations, previous scars or open wounds. And at the end of the day, it's a 1 + 1 = 3 situation when we can take care of these patients together collaboratively. Thank you again for the honor and opportunity to present, and I'll be happy to take any questions.
Thank you very much. I think that was brilliant, Jeff. It was absolutely amazing to see all these pictures and videos. I think you are up for some questions now.
Of course. I saw one question about how to deal with the multitude of incisions and scars that patients oftentimes will bring to the table. And so I have a few basic principles that I follow. First of all, it's all about anatomy and it's all about blood flow. And one thing that I would say plastic surgeons are keenly aware of is it's not what you take, it's what you leave behind. So if you take a look at the geometric or geographic map that patients often have on their abdomens, I start to visualize where is the blood flow coming from to supply the blood flow to the soft tissues of the abdominal wall. For that, in my head, I've got a paradigm, maybe a picture. I don't know if you are familiar with the Huger zones originally described in 1979, but they divide the abdominal wall or the soft tissues of the abdomen up into 3 zones, 1, 2, and 3. And it just depends on which zone, so which artery supplies which zone. So choices are going to be like the deep inferior epigastric, the superior epigastric, the circumflex iliac, the intercostal, the subcostal. So these, when you take a picture of a patient or see them in clinic and you superimpose in your mind this map of where the blood supply is coming from, you can see where the incisions have cut across previous blood flow. And now you start to visualize your upcoming surgery and the incisions that are necessary for that. And you just have to pre-plan and figure out how not to obliterate some of the residual blood supply. In some cases, I must say that's quite difficult. You know, if you have a patient who has a previous vertical midline and let's say a right upper quadrant Coker incision from a previous open cholecystectomy, and then if they have also had a previous low transverse incision for some reason, that becomes a huge challenge. And so the second strategy, besides trying to figure out in advance, pre-planning where the blood flow is coming from, is minimal undermining. So even in previously operated areas, you can have some revascularization through smaller arterioles. It's not the same robust axial blood supply, but if you could avoid excessive skin flap undermining in the areas of previous scars, or you just confine your undermining to exactly what you need to get your operation done, that's another minimization strategy from a risk perspective.
So
go ahead.
Yeah, so I have a direct question for you, Jeff. Let's say there is a subcostal incision and a groin incision for a hernia, and there's a midline hernia, and it's got to be an open hernia surgery. What incision would a surgeon now give, and what kind of component separation would you advocate in this patient?
Is it a ventral hernia?
Yeah, it's a ventral hernia. Midline incisional hernia. Yeah.
I would do, so in that situation, I would do a reopening of the vertical midline incision. I would leave the other incisions intact. I would perform preferentially a posterior component separation or transversus abdominis release, because that will obviously minimize any disruption to the soft tissues of the abdomen. If that were not available because of multiple previous operations or obliterated planes, I would switch to a minimally invasive anterior component separation, and I would do it on the left side because that lacks the subcostal and the groin incision that you said were on the right. So you can determine the laterality that you need, and I would start with the left. Now, if you needed to do a right, so let's make this even more complex. If you needed to do a right and the TAR plane was not available for whatever reason, you still could perform a minimally invasive anterior component separation on the right. And that would mean about a 5 centimeter subcutaneous tunnel that is working from medial to lateral at a level just above the anterior abdominal fascia until you get to the semilunar line. And then you would dissect about a 2 centimeter wide tunnel superiorly and inferiorly using a narrow deaver, for instance, to help facilitate exposure. And you still can perform your anatomically precise external oblique aponeurotomy and your delamination of your external from your internal, all through that small soft tissue, minimally invasive approach. This was described by Chuck Butler from MD Anderson, who I mentioned in this last article or last presentation. And he has very favorable results, especially vis-a-vis the old school open approach. So basic principles would be know your blood supply, minimize your undermining, and basically the last part is when in doubt, you could use technologies like I just described, which is the indocyanine green angiography.
Okay, in the interest of time, I will have to fire a lot of more questions, Jeff. So can we add panniculectomy to component separation technique? Are you okay?
The short answer is yes, you can, and the data is mixed. You will find mixed data on some people find it better, some people find it worse. It depends on the author. In general, I think the answer that I adhere to after reading all of it, and we even published on it ourselves, is yes, in the right patient, it is possible, but they have to accept a higher complication rate, especially of skin and soft tissue minor complications.
Yeah. So you did mention in your talk that you do look at obesity as a deterrent to ventral hernia repair, but you do look at plenty of things. Is BMI the only thing you look at? Do you look beyond BMI? And what is your BMI cutoff when you say, no, I'm not going to do any open ventral hernia surgery on this patient? And I think all the hernia surgeons out here are probably looking at an answer on this particular question, which has flummoxed us all for a long.
Agreed. A very challenging question that we all face. So I'll be super brief and I'll give you bullet point answers. The first question was, is BMI the only consideration? No, it is not. The second question is, what other things do I consider? And the important comorbidities that I take into account, and this list is not exhaustive, but I'll again be poignant. Number one is BMI. Number two is smoking. Number three is diabetes. Okay, so I'll start with those three. BMI cutoff is 40. I'll go to 42 on occasion, as long as you're asymptomatic. If you're symptomatic, then obviously you may, if the patient has been recently admitted for multiple small bowel obstructions, treated non-operatively, you can't treat them as a completely elective case. You may have to, incur the increased risk and go ahead and do the surgery. But in the completely elective case, asymptomatic, I like to see a BMI below 40. Smoking, no smoking. Matter of fact, no nicotine whatsoever for 30 days prior to and after the operation. I confirm that with urine and or blood tests. If you're concerned about pulmonary reserve, it usually takes up to 6 weeks to regain ciliary function after smoking. So I'll wait 6 weeks instead of 4. That's from a wound healing perspective, 4 weeks before or 4 weeks after. Sorensen published on that in 2012, meta-analysis of 500,000 patients. And basically the bottom line is you can never get back to the risk of a non-smoker, but you can mitigate your risk by making them a former smoker as low as you can. And that's 4 weeks before or 4 weeks after. Diabetics, I like to see a hemoglobin A1C less than or equal to 7.4. If it is 7.5 or above, they don't get surgery from me. All of these, I'm summarizing an immense amount of literature into kind of bullet point form, just again, for the sake of time. And we also published on this, and I can give you the reference and maybe put it in the chat bar if I have a second, of where we published a more thorough explanation of some of these criteria.
Excellent, Jeffrey. I really enjoyed your lecture, and I was wondering, looking at the pictures of your patients, my question is very simple. There's 2 points I just want to ask. One is, you said minimally invasive anterior component separation. So just want you to elaborate a little bit on that. And second question is, do you get primary this giant hernias, or you are called up by the general surgeons for repair of these hernias? How does it work out?
So let me see if I can pull up for you. Give me 1 second. I have a lecture that, interestingly, right after this one, I am giving to Bangladesh, Nepal, and India for plastic surgeons. And in that lecture, I have a video of the minimally invasive anterior component separation. I'll see if I could bring it up, if it'll pop open. And if not, then, you know, for sake of time, I'll just keep going. But it basically involves, and it looks like it's not popping up. Oh, here it is. Okay, I'm going to see if I can share my screen. And give me 1 second. Let me go to this. Do I have authority? Yes, I do. Can you guys see my screen?
Yes.
Okay, so I'm going to see if I can show you this. This is if you can see this movie, this is like a 30-second movie that will probably give you more visual explanation as to a minimally invasive anterior component separation. You can see I dissected a 5-centimeter wide tunnel that is the width of a large deaver working from medial to lateral. And then now I'm using that small narrow deaver to dig along the semilunar line, just about 1.5 to 2 centimeters lateral to it. I use this non-conducting plastic Yankauer suction tip in order to perform the external oblique aponeurotomy. Then I delaminate the external from the internal oblique. You can do that using the spreader dissector, which is just an instrument I invented, but I don't get any royalties from it. Or you could use electric cautery. And then at the end, you know, you close your fascia in the way that we've already described. And so that right there, and I'll just stop sharing now, that's just a quick 30-second blurb about how to do a minimally invasive anterior. The bottom line there is that when this was described in 1990 by Oscar Ramirez and published in PRS, they talked about widely undermined skin flaps that obliterate every perforator to the skin. And while that was effective to achieve midline musculofascial closure, that also begot an incredible amount of complications related to soft tissue. So as we better understood vascularity to the abdominal wall, we could refine our techniques so we didn't have to obliterate all of those important perforating vessels. Just because they're small doesn't mean they're not mighty. So we need those vessels, you know, to help mitigate against complications. Second question had to do with what again?
Does this giant hernias primarily come to you, or you are called up by your general surgical colleagues?
So both. We have an interesting setup here in Columbus. It's the same setup I did in Dallas when I was there. So when we see patients, we see them together. So I have what I call a hernia clinic, and I have them once a week, and I see patients with my general surgery colleague who comes over to my clinic, and it's very patient-centered. So when a patient comes in from near or far, they park their car in a easy to find, free surface parking lot. They walk up one flight of stairs or take the elevator, and they see two doctors at the same time, the hole diggers and the hole fillers. And we basically sit there and we get all of their information in advance. We have their scans in advance, their previous operation notes in advance, and they spend about 45 to 60 minutes with us, and we craft a plan together, and the patient walks out with the answer, you know, at least the proposed plan. And there's no phone calls afterwards. There's no 2 visits, 2 doctors, 2 different days, terrible inconvenience to the patient, the need for coordination on the backside. We like to do it all together in real time with the patients, and they get a lot of satisfaction from that. So that's how we've set it up. So the giant hernias come through that mechanism.
Yeah, Vandana, you want to ask a question, I think.
Yes, there's something that was coming to my mind, Dr. Jeffrey. I think that was a wonderful talk and really enjoyed it very much. Has there ever been a situation wherein, despite the component separation, or prior to having done any of this, you haven't been able to really approximate the muscular layers or the aponeurotic muscular layers in the midline? And what exactly have you done in that situation? And second, what is your experience with meshes? Do you use a mesh?
These are great questions. Again, for the sake of time, I'll be brief. Have I encountered that? Yes. Do I like to encounter that? Absolutely not. Other things I did not mention that I think are deserving of at least mention here today is that when you see these types of patients in your office, you can predict some of these patients in advance because you see that their hernia is quite wide, or the loss of domain is large, or a combination of that. What you can't see on a CT scan is compliance of the abdominal wall tissues. And so, you know, that's where the X factor is. Sometimes you get caught in a situation where you think you have enough and you've planned in advance, but the compliance of the soft tissues, you know, from previous operations typically is really scarred down. It doesn't give you the excursion that you need. Now, one thing we didn't mention today is the use of botulinum toxin or Botox for regaining domain and obtaining midline closure, especially in these complex situations. I have no conflicts of interest to report. I do use this as an adjunctive technique. I use described techniques that came out of Mexico, refined by Todd Henneford's paper that he just published a few months ago in the Journal of Surgical Research. 3 weeks in advance, we're doing 150, 200 units per side. That's 3 weeks in advance of surgery. That gives us this chemodenervation of the obliques that allows us to medialize the muscles with a greater degree than we could before, at least for the 3-month duration of the Botox, and get the situation closed. If you're in the operating room and you've done everything you know how to do, including dissecting these component separations to their maximal extent, and you still find yourself short, in those situations, I usually convert to a biologic mesh, because I don't want to place a synthetic mesh as a bridge where it's going to be up against a less vascularized subcutaneous tissue, right? You don't have muscle on top of this. You have fat. Fat is not very vascular. Now, I know some of my general surgery colleagues here in the United States, in those situations, I've heard them talk on panel and podium presentations about putting in a microporous, heavyweight, bridging synthetic mesh. I just don't agree with that, because we know from basic science studies that microporous, heavyweight polypropylene meshes do not resist infection very well. If those were to get colonized, let's say from a cellulitis or a seroma turned abscess, because of its exposure to the fat, you're going to end up having to remove that mesh. In other words, a reoperation, and you don't want that. So I'd prefer the better safety profile of a non-cross-linked porcine. Now, that being said, your last question, I use mesh routinely. I use different kinds of meshes. My main go-to is a macroporous mid-weight polypropylene mesh, usually placed in the retromuscular space. But that's my go-to, and then it just varies by patient after that.
Thank you, Dr. Jeffrey.
Sumit, you want to ask something?
Yeah, Dr. Jeffrey, thank you for a wonderful talk and answering all those questions. I wanted to ask you about the rectus diastasis, because there's a lot of controversy amongst the hernia surgeons whether we are over-treating or under-treating the divarication of the recti. It's very common in overweight to obese people, and these patients usually have umbilical or paraumbilical hernias. And should we actually repair the diastasis of recti? How important is it to restore the abdominal core health? So what's your take as a plastic surgeon on management of the diastasis of recti along with the umbilical or the paraumbilical hernias?
Great question. I am going to pull up, let's see if this will do it for me. Give me 1 second. I'm going to call it diastasis. So I don't know if you guys saw this. This is obviously a very common question. And let me see if I can pull up the cover of this, and it's not pulling up instantly. So I'll just leave that for now. This month's hernia journal, Giampero Campanelli from Italy is the editor-in-chief of the journal. And he asks the same questions that you do. And so he tapped Greg Dumanian from Northwestern, David Ross from the UK, myself, and was there one other person? I think there was one other person. to co-edit basically solicited articles on this. And we actually just published on this question, and it just came out 2 weeks ago. And we looked at laparoscopic and open approaches. And the bottom line is that if you have hernias within weakened diastatic attenuated fascia, that clearly is a weak point for a future hernia. Plus, if you plan on doing any sort of repair, including a suture repair, you're already putting that stitch through weakened tissue, and that will increase your complication rates in terms of recurrence. So you want to get back to healthier fascia for reapproximation. And that's actually a basic principle that I use even in my non-diastasis patients. Oftentimes, as you know, when we operate and you get in there, you see this attenuated, marginally viable diastatic linea alba, or even hernia sac that's left over in the midline. And I think a lot of our recurrences are because we're afraid to get back and create a wider defect by resecting that tissue. I think that's a basic principle we often overlook. I'm not afraid of digging bigger holes because I feel comfortable reconstructing bigger holes, but I'm not going to leave bad tissue behind. So I will take away any diastatic tissue, and then I will take healthier musculofascial tissue and reapproximate that at the end. And again, I wish I had the article that I could pull up for you, but like instantly here on the fly. But if you just go to this month's hernia journal, there's a series of articles on rectus diastasis by authors around the world. And I think it would be helpful to take a look at that.
So Jeff will not leave you here. Diastasis with a parambolical hernia, your approach. All the hernia surgeons are watching here now, and they want to know there's a parambolical hernia with a W2 diastasis. Am I going to do a laparoscopic approach, an E-tip approach, LR approach, or I'm going to do an open abdominoplasty? Which one is your go-to tool?
So the first question you have to ask in that situation is, and at least I'll confine this comment to the United States in particular because of how our insurance companies work here, okay? But just to tell you from the outset, there is not any insurance company in the United States that I currently know of that will pay for a rectus diastasis repair. They will pay for the hernia repair. They will not pay for the diastasis repair. I've tried a million times through years. It doesn't matter how wide it is. It doesn't matter how symptomatic it is. They will not pay for that. So that's not a consideration. The second consideration, is there extra skin, and is the patient bothered by it? If the answer to that is yes, then the answer to the question is abdominoplasty, because no matter what you do otherwise, there's no operation that's going to remove that extra skin. For instance, if you chose to do it laparoscopically, assuming that even insurance would pay for it, let's say they will, what is that going to do for the extra skin that the patient's concerned about? So if the patient is concerned about extra skin, the answer clearly is an abdominoplasty, and that's usually in the wheelhouse of a plastic surgeon. If the skin is not a consideration, you could either do open or laparoscopic, and I would repair the diastasis at the same time.
Would the mesh go, would it be a mesh repair, and where would the mesh go in your hands?
No, it would not be a mesh repair for a simple diastasis in a simple hernia. You can imbricate the rectus diastasis. I have a whole separate lecture on rectus diastasis. Maybe we can do that some other time. But the bottom line on that is that it doesn't matter whether you use long-acting resorbable or permanent suture. The results are the same. What you don't want to do is use short-acting resorbable suture. You don't want to put excess tension on it. The failures have occurred when you're trying to plicate too much tissue. One study from Van Uchelen talked about using Vicryl to reapproximate the lateral rectus borders. That's not going to work, and it failed over 40% of the time. But if you use PDS or Prolene or nylon or what have you, and you reapproximate the diastatic medial borders, and you could use 1 or 2 layers, then using ultrasound, CT, or MRI objective evidence, long-term results are durable without the need for mesh. So again, like in those situations, it's usually a suture repair, 1 or 2 layers, long-acting resorbable or permanent, take your choice, and mesh is usually not required. The caveat to that is that there are some who believe that mesh is necessary, especially in the widest of diastases. I don't disagree with that. That's more like a hernia than a diastasis. And at that point, if I were to repair it, I would resect the diastatic fascia and do a retrorectus sublay of macroporous mid-weight polypropylene mesh, or self-adhering polyester. One of those two mesh options. Greg Dumanian has written on this, and that article is also in this month's Hernia.
All right. Vivek, you wanted to ask something. Please go ahead.
Dr. Janis, absolutely wonderful insights, and it has been a pleasure listening to you over the last 1 hour. I rarely see a plastic surgeon doing so much into hernia space, talking about endoscopic, laparoscopic, open hernia repairs, and the component separation techniques. We have been collaborating with our plastic surgeons, I would say just a bit, for reconstruction of flaps and, in difficult abdomens. But how do you see on a larger scale, we who are more fond of minimally invasive hernia repairs and, ETEP TARs and all that stuff, collaborate with the plastic surgeons who are mostly doing open surgeries, who are mostly into abdominal flaps, and so how would you see it on a larger scale? How can that association grow? And how would you, any tips to create that kind of collaboration in our own institutions so that we can go to the next level of hernia surgery?
Yeah, I think that collaboration always is a win, no matter what. It's amazing, because we all live in our own little worlds. And then you start opening up these worlds to people with other expertise, other backgrounds, other experience levels, and you see how much they add to the equation. And so I believe that collaboration can exist on multiple levels. Now, the way that we do it where I'm at is that the general surgeon does the exploratory laparotomy, the lysis of adhesions, and any bowel work that's necessary, fistula takedown, ostomy creation or takedown, etc. Small bowel resection. They do all of that. I do the rest. I do the muscle work, I do the mesh placement, I do the skin work, and we both co-manage the patient afterwards. It's not one or the other. It's both of us as equals managing the patient, playing to our strengths. So how might it work in a situation like you just described? Well, again, skin is an important component, and actually knowing how most general surgeons operate, I tried to tailor the talk that we just gave to skin. I didn't really try to focus on muscle work and stuff. That's a totally different lecture. So if you're in a situation where a patient comes to your clinic and they have too much skin, too little skin, you don't know what to do because of multiple previous scars, then, in any of those situations, I think getting a plastic surgeon involved is going to help, even if you do it robotically or laparoscopically. Because there still are extra situations that you have to deal with that pertain to soft tissue, and that is certainly the domain of a plastic surgeon more than a general surgeon. So the other thing is getting a consult from a plastic surgeon just to pre-plan some of these is also helpful, even if it's just conversation and not participation. I learned a lot just by listening to other people, and I think that the conversation can be had at any time.
Right. So Jeffrey, I think we just got about 5 minutes for you. Is that right? For your time?
Yeah, I think I have to log on to the other countries in about 3 minutes. So
okay,
I'm happy to answer maybe one more question if you've got it.
Yeah. So you could do, let's say in a hypothetical case, both ACST minimally invasive putty modification versus a PCST TAR. Which one are you going to prefer? And what is this maxi mini approach that we should know that you have written so much about?
Yeah, the simple answer is I think everybody should learn to do everything. Because if you just have one hammer that hits every nail, you're going to come into a situation where you wish you had more tools in the toolbox, and it just doesn't work, So I actually, in reading the studies, have seen that there's no definite advantage of one over the other. I think we have basic principles that we adhere to. Don't disrupt blood supply. Mesh reinforced repairs are more durable. Mesh, if it can be excluded from the intraperitoneal cavity, is more favorable in terms of complication rates. That being said, I think that, if you know how to do a good minimally invasive anterior and a posterior, and you also may be familiar with other adjuncts, like as Dumanian describes the mesh strip situation, I think it's just important to know it all. So I actually do all of it. And my favorite approach is a standard retrorectus self-adhering synthetic mesh with minimal undermining. I love that. The problem is that my practice doesn't really see a ton of those patients. I kind of see some of the other more complicated situations that involve bigger pieces of mesh or more issues that demand a component separation. The Maxi Mini is just meant to say that you can do an open procedure and still use minimally invasive techniques to adhere to these principles. So I know that in the past, I've heard other people say that in order to perform transfascial suture fixation of the mesh, you mandatorily have to undermine wide skin flaps to do that. And you don't. You could use a Reverted needle, a Carter-Thomason suture passer. You could use these laparoscopic approaches so you don't have to undermine skin, and you still can securely fixate the mesh in whatever position you want it to be fixated in. And you just don't have to do the big open procedures that were wide open that we used to do. So that's the Maxi Mini. And there's nothing special about it. It's just we published some evidence using these basic principles and it works.
Thank you very much. I think, Jeff, it has been a pleasure, and I don't want to detain you. I know you have another meeting just coming up, and it's important from, I think, Professor Sunil Popet, are you here? Would you like to thank Jeffrey? He's the president.
Thank you, Jeffrey, for coming to the IAGES podium. And we would love to have you again in some time. And we have so many colleagues and our PGs who would love to learn a lot of things from you based on what we saw today. And wonderful lecture, and all the best for the future. Thank you so much for being here.
Thank you. It's been an honor, like I said, and I'm happy to come back at any time that you wish. So thank you again. I hope you guys have a good rest of your evening.
Thank you.
Thank you, Jeff.
Bye-bye.
Thank you very much. Really obliged.
Thank you very much. Thank you.
Bye-bye.
Right. So Rameshda, can you take it from here for the next session, please?
I thought I was there only for the first session.
We are not letting you go anywhere.
Okay. So I think we've had a very excellent session. And now the next speaker is Dr. Sarfraz Beg, who is also the coordinator of this program. Sarfraz is...
Rameshda, I think Sumit has to leave. So can he do it first?
Okay. So, so just a bit of a change of program. So we have Sumit Shah, who's also a very dear friend, a very enthusiastic hernia surgeon, but he's also a very excellent surgeon, very academically active, and he's always there. He never says no. You just have to give a call to Sumit, and Sumit, we want you to be there, and he's always there. So it's always nice to have Sumit with us. And I always, whenever I meet him, I tell him, Sumit, I want to clone your brain. And Sumit is aware of that, and he's scared that I'm going to clone his brain. So over to you, Sumit, for your talk, Hybrid Repairs, Best of Both Approaches. And I will also temporarily take off because I have a dinner coming. So Sumit, all the best, and over to you.
Good evening, friends, and welcome to this edition of IAGES session on management of ventral hernias. At the outset, let me give my thanks to IAGES, President Sunil Popet, and the organizing chairperson for this course, Dr. Sarfraz Beg, for inviting me to present my views on hybrid approach to complex ventral hernias. At the outset, I would like to say that I have no disclosures to make, and also some of what we talk about may not be having a very strong level of evidence at the current times. However, as we go along in the journey of our hernia surgery, learning newer techniques, I'm sure the evidence will come along the way. So friends, we know that for groin hernia, we have got revolutionary results. And in the last 25, 30 years, the totally extraperitoneal and the transabdominal preperitoneal repairs have brought about revolutionary results. The incisional hernia repairs, though still is a challenge, there are various options. And we know that from the time in 91, 92, when the intraperitoneal onlay mesh technique was described, till 2015, or till 2012, when intraperitoneal onlay mesh technique was a gold standard, nothing much changed really in the MIS hernia repairs. But however, there is a plethora of techniques that have come up in the last 5 to 7 years. And therefore, there are various options, but there is no gold standard. Often what we do is based on the surgical tradition of what we have learned in our training. But does this hold good in complex hernias? So these are some of my patients. You can see that one patient has got a complex large flank hernia, right lower right iliac fossa hernia. Another patient has got a large lower midline hernia, while the third patient has got a large subcostal or an epigastric hernia after a coronary artery bypass. So all these hernias, which are large and are present at atypical locations, can be a challenge to repair. Now, onlay mesh has been the traditional technique which has been done over many, many decades. Technically, it is easy. It has got a short learning curve. However, we all know about the risk of complications, seroma, SSI, and skin necrosis, flap necrosis, and more, which happen with the onlay technique and the anterior component separation. Now, we know according to the Pascal's law and integrity of the mesh, if you place the mesh by the onlay technique, any increase in the intra-abdominal pressure exerts lifting forces against the mesh, and it's a less stable repair. However, when we do a sublay repair, whether we do a retromuscular repair or an intraperitoneal mesh repair, equal amount of forces are exerted across the mesh, and the mesh unites and consolidates the abdominal wall. Therefore, according to Pascal's law, a sublay repair or an intraperitoneal mesh repair with a wide coverage after the closure of the defect will give you a much more stable repair, and you will not need to create large flaps and have soft tissue problems as in the open onlay technique. Now, lap ventral hernia repair is of course favored repair in the abdominal wall defects because of reduced post-op pain, surgical site infection, and length of hospital stay. However, if the defect is more than 10 centimeter, there could be higher complication rates. Seromas are common, and therefore, I think now it is quite clear that anytime the defect is above 2 centimeter in size, definitely we need to close the defect and we need to do an augmented repair. So instead of doing just an intraperitoneal mesh repair, we need to do an augmented intraperitoneal mesh repair with defect closure. Now, once we do that, we know that there is minimal dissection involved, so the tissue planes are relatively well preserved. We don't need to do large intramuscular, retromuscular dissections. There are less chances of entering a wrong plane inside the abdominal wall, less damage to the tissues because there is less tissue dissection. You could possibly place the mesh retromuscular in a reef topa fashion or even in an intraperitoneal, preperitoneal fashion. Now, this bouquet of the repairs, either a preperitoneal retromuscular or the intraperitoneal repair, have given or evolved into a hybrid approach also, where we can close the defect and use a different plane for the placement of the mesh. Now, one of the advantages of the hybrid approach is a lower recurrence and lower wound complications. Now, I'll give you certain examples of cases which will highlight the way that hybrid approach has worked in our clinical series. Now, this is one of the patients. She underwent a gallbladder surgery in 2010, followed by a laparoscopic nephrectomy and an open hysterectomy, bilateral salpingo-oophorectomy at the same time in 2012. Now, patient had a large incisional hernia in the lower abdomen. So she came to us for repair of the hernia, but her BMI was 55. So she was severely obese, and we opted to do a laparoscopic sleeve gastrectomy first in 2014. Now, once we did the bariatric surgery, she lost in 15 months about 50 kgs, and her BMI came down to 55, from 55 to 34. However, she had a huge pannus with a defect of 9 centimeter by 8 centimeter by 8 centimeter. Now, conventionally, one would imagine that, having this large defect, 9 centimeter by 8 centimeter, to close this defect may be conventional imagination would mean that you would require a kind of component separation. However, as you can see, because of the loss in weight and because of the pannus, her abdominal wall was very, very compliant, and we could actually go first by laparoscopy, do the entire adhesiolysis. Whatever, there were minimal bowel adhesions, but all the omental adhesions could be lysed. And then actually we did a formal abdominoplasty in her. So you can see these trocar placements are there, which were used for initial laparoscopy, look inside, adhesiolysis. And then we did an open abdominoplasty. We closed the defect, and then we put in a large mesh from inside rather than putting it on the outside, because we know that there is seroma, there is SSI, more chances of mesh infection. And once we could give a wide cover by placing an intraperitoneal mesh, and then you can see this is the post-operative, immediate post-operative, and the patient has got a repositioned umbilicus and a large mesh, which is intraperitoneal mesh, which is according to the Pascal's law. And you can see the pre-op photograph, which showed a large pannus. The pannus has been relieved. The defect has been closed without any component separation. And we have placed a large mesh in the intraperitoneal position, so that according to Pascal's law, it is a more favored location rather than putting on top of the anterior sheath. So this kind of repair worked very well in this lady. Another case, 70-year-old lady, diabetic, hypertensive, hypothyroid, grade 1 obesity with recurrent incisional hernia. She had a cesarean section, cholecystectomy, hysterectomy, and even an open primary hernia repair, that is without mesh. She had a lower midline scar with multiple defects in the infraumbilical and a weak umbilical area. So you can see that is the previous scar, and you can see the hernia. Now we need to reinforce the entire scar. So we know that she has got a weak umbilicus. There is a paraumbilical defect. There is a lower midline defect, which is also along the incision, and we need to reinforce the entire incision. Now, once you do, whether you do it open or whether you do it retromuscular, you will need extensive amount of tissue dissection. So what we did was, this is the intraperitoneal picture. There were a lot of omental adhesions. The omentum was densely adherent because of the previous sutures. We had to lyse all of that. And then we gave a small open incision, and we could easily run and close all the defects from outside with just a PDS-2O suture. Once we did that, we could apply a wide overlap intraperitoneal mesh without wide tissue dissection. And this is the post-operative look immediate. You can see that we have actually made her scar more cosmetic. We have actually closed the defect. We have done an augmented repair. And without any extensive tissue dissection, we have put in a large 15 by 20 centimeter to cover the entire incision and a wide overlap from the midline. Now, this subcostal hernias, which is always again a challenging problem. Either people do an open anterior component separation or they do a transabdominal pre-peritoneal. But in this 55-year-old diabetic lady with post-CABG, the subxiphoid hernia was 9.5 into 9 centimeter. Now, because of the bony landmarks and being in the subcostal region, closing the defect purely laparoscopically, it is sometimes not feasible because the tissues don't come together. Now, if you do a retromuscular repair, you may require a transversus abdominis release to be able to close this defect, and also it will require a lot of tissue dissection. If you do an anterior component separation to close this defect, again, it is going to require a lot of tissue dissection. This is the CT image. You can see even the part of the left lobe of the liver is going into the hernial sac. Now, what we did was that we went through laparoscopy, we did all the adhesiolysis. And once we had done the adhesiolysis, we gave a small limited open incision, and we gave some relaxing incision, not a complete anterior component separation, lateral on the anterior rectus sheath, lateral to the rectus muscle. You can see that cut edges which are showing the release incision, and we could close the defect in the midline without doing a full anterior component separation from subcostal area to actually absolutely the inguinal canal. So it did not require that level of component separation. It did not require a transversus abdominis release to close this defect. And then we could go inside and again place, like is seen in the picture, a large 15 by 20 centimeter mesh covering the entire area. So another, case dealt which would otherwise not have been possible purely by laparoscopy or by, component separation, it would have become a much more major operation. Now, one of the last cases, again, 65-year female, COPD, normal BMI, past history of laparotomy with Wardheim's hysterectomy, 12 by 10 centimeter, defect in midline and right lower abdomen. Now, once the insufflation is done, you can see that such a huge sac ballooned up is there. Now, if this patient requires an open component separation repair, then you can imagine the amount of tissue dissection that is going to be there. So what we did was, you will realize that these patients, especially many of the Indian middle-aged ladies, have got very lax abdominal wall. Their defect closure does not really require, it looks like a very big hernia, but we gave an incision, we excised the entire extra skin to make it much more cosmetic, which anyway we would have to do. Otherwise, this lax skin would be continuing to be giving her cosmetic problem. And we closed the defect. You can see that is the edges of the defect. We closed the defect, and you can see here, we have given her sutures, and then we could go in and we could actually create the preperitoneal plane in the lower half to do a trans-abdominal partial extraperitoneal, and we could put in a large mesh, and the lower edge of the mesh was fixed to the pubic bone, and then we could put in a large mesh to cover the defect from all around. So advantages is that it is technically easy, much more easier than doing complex component separations. Many times it is, it is easily reproducible by many surgeons. Prosthesis is in ideal position. So it is either, you could do a hybrid with placing the mesh in the retromuscular position also, or placing the mesh in the intraperitoneal position also. We do not do extensive new planes dissection. So every case does not, if it is 8 to 10 centimeter defect is there, it is not imperative that you will have to go with component separation technique. You can use these hybrid techniques, and many times it is possible to close these defects without using component separation. Because you are excising the sac completely, there are minimal chances of seroma. If it is an incisional hernia, you can actually make the incision better. Wound complications, most of them were minor. And in our series, I think it is mentioned 20, but they were less than 10%. There was no mesh infection. And I say that because sometimes earlier, when we used to present our hybrid repairs way back in 4 or 5 years back, everybody was scared that the mesh that is being placed inside will get infected because we have opened the abdomen on top. So, but we have not faced any mesh infection, and in the short follow-up, there is no recurrence in our series. What are the disadvantages? Initial cost may be higher if we are using the composite mesh and the intraperitoneal mesh. But if you are doing a retromuscular hybrid repair, you can actually reduce the cost. Now, long-term cost can also be reduced because of, there are less recurrences, less chances of multiple admissions and infection. Hybrid repairs have not only been used along with the intraperitoneal mesh, but many times those who are doing TAR operations and endoscopic ETEP TAR operations, and they have found large sac, then they can do in all the endoscopic dissection, then just give an open incision, excise the sac and close the defect from the open incision, and then put a retromuscular mesh. So friends, the conclusion here is that complex hernias always pose a challenge, and what is the best approach to it will depend also not only on the training of the surgeon, but what are the facilities available, what is the cost that the patient can afford, and therefore the treatment has to be individualized. So there is no single conventional procedure which can be optimum for all cases. And therefore, hybrid approach is a good option where you can actually improve the scar, which is because of the previous incision. You can close the defect, you can excise the sac, you can place the mesh in intraperitoneal, or if you want in a preperitoneal retromuscular position. Technically, it is easier than doing difficult component separation techniques, and all patients with 8 to 10 centimeter defect will not require a component separation technique, especially if the abdominal wall is lax. It is safe and it is effective. Thank you. Success in hernia repair, it is something which is just ahead, and sometimes it is also elusive. So I am sure that you will use judiciously the technique which is suited best to the patient, which is suited best to you, and also to the circumstances in which you are taking up the case. Thank you once again, IAGES. Thank you, Dr. Baig, for this opportunity.
Thank you, Sumit. Excellent talk on a very favorite procedure and which makes life easy for so many of us. And now I would request Dr. Sarfraz to speak on a very exciting topic. Don't let fat spoil your hernia surgery. Over to you, Sarfraz.
Thank you. I think the video will speak by itself. I don't want two Sarfraz to bombard the screen. One should be enough.
Hi, this is Dr. Sarfraz Baig. I bring greetings from Digestive Surgery Clinic. I thank Team IAGES for giving me the opportunity to speak on the management of ventral hernia in obese patients. And this talk is limited to elective cases and not to the emergency ones or the symptomatic ones. I wanted to title this as Don't Let Fat Spoil Hernia Surgery because really when we see obese patients, they have this very naughty tendency to spoil our ventral hernia repair. Although there is lack of level 1 evidence, it is believed that obesity can lead to increased recurrence, surgical site occurrences, infections, and medical complications when it comes to repairing ventral hernia. There are plenty of questions, however, which are unanswered. Like, for example, what BMI should we take beyond which hernia surgery should not be done? Is that applicable for small defects too? And is BMI the only criteria for qualifying obesity? If the obesity is indeed a huge deterrent, when is it that we will say bariatric surgery is indicated? And can bariatric surgery and hernia repair be combined? If we were to do hernia procedures, what procedures would we choose for a simpler defect and a more complex defect in these obese patients? Hi, this is Dr. Sarfraz Baig. I bring greetings from Digestive Surgery Clinic. I thank Team IAGES for giving me the opportunity to speak on the management of ventral hernia in obese patients. And this talk is limited to elective cases and not to the emergency ones or the symptomatic ones. I wanted to title this as Don't Let Fat Spoil Hernia Surgery because really when we see obese patients, they have this very naughty tendency to spoil our ventral hernia repair. Although there is lack of level 1 evidence, it is believed that obesity can lead to increased recurrence, surgical site occurrences, infections, and medical complications when it comes to repairing ventral hernia. There are plenty of questions, however, which are unanswered. Like, for example, what BMI should we take beyond which hernia surgery should not be done? Is that applicable for small defects too? And is BMI the only criteria for qualifying obesity? If the obesity is indeed a huge deterrent, when is it that we will say bariatric surgery is indicated? And can bariatric surgery and hernia repair be combined? If we were to do hernia procedures, what procedures would we choose for a simpler defect and a more complex defect in these obese patients? Now, just to put that into a visual perspective, I have made 4 categories, and I would like you to think while we go through these pictures, what is it that you would do in your practice? This is the BMI 32 patient with a 2 centimeter umbilical hernia. What would you do for this patient? This is a BMI 40, again a 2 centimeter umbilical hernia. Would you do the same thing as you did for the first patient? This is a different patient. It's a 12 centimeter wide incisional hernia, lower down, M4, and the BMI is 38. It's a gynecoid obesity. It's non-diabetic, this patient. And then this is a patient whose BMI 40, android, diabetic, got a 12 centimeter wide incisional hernia. And this looks like it's an irreducible hernia. So in these patients, what is your approach? Now it's important to have some plan in your mind because failing to plan is planning to fail. We wanted to devise a clinical pathway for ourselves, and to do that, we searched the published literature to find out how we can be guided. Unfortunately, as Oscar Wilde said, the answers are all out there. We just need to ask the right questions. In the digital world, all we need to do is put the right search words in the PubMed, and we got a few answers. George Ede et al. Did a lot of good work and published his work in 2013, where he looked at a small case series with an algorithm. And in these obese patients, they categorized the obesity in hernia into favorable and unfavorable anatomy. In terms of obesity, BMI less than 50, body wall thickness less than 4 centimeters, and a gynecoid obesity comprised a favorable anatomy, whereas the converse became an unfavorable obesity. Now, 50 was an arbitrary cutoff. As far as body wall thickness is concerned, there are earlier published literature which show that more the subcutaneous fat, more the SSI. And finally, between gynecoid and android obesity, there has been a lot of literature in the past, not only pertaining to ventral hernia, but also pertaining to colorectal surgery, suggesting that an android obesity patient fares much worse than a gynecoid obesity. The reason being android obesity is linked to metabolic syndrome. More the visceral deposition in the central part of the abdomen, higher the chance of the patient getting a diabetes, liver disease, and cardiac disease. It's also important to remember that patients with android obesity predictably have a higher intra-abdominal pressure, and this can be counterproductive as far as ventral hernia repair is concerned. On the other hand, gynecoid obesity offers no such problems. A hernia could be favorable and unfavorable according to the same paper if the hernia is in midline reducible and the width is less than 8 is favorable and the converse is unfavorable. Based on favorable and unfavorable anatomy, they have recommended doing concomitant hernia surgery with bariatric surgery in the form of sleeve gastrectomy in favorable situations, and in unfavorable situations, they have advocated doing a bariatric surgery first, optimize the patient, and do a staged ventral hernia repair later. Although this algorithm may be simple and may be good, they reported only 3 out of 28 cases as recurrence. We have a problem with this algorithm because many patients in our cohort refuse bariatric surgery. 2, we do not find BMI 50 cutoff as something that is acceptable in our practice. And finally, concomitant surgery is something that we do not do, A, because there is a report of higher mesh infection, 2, subacute intestinal obstruction, and it does compromise the quality of both the hernia surgery and the bariatric procedure as well. And since we do not use biological mesh in our practice because of the cost in our region, concomitant surgery is something that we haven't yet toyed with. What about the BMI cutoff? 50 was too high for us, so we delved into the literature and we found that in the early 21st century, there were some case series which showed that IPOM in obese gave a recurrence rate of around 5%, which was comparable to the one in non-obese, whereas some papers suggested that the recurrence is higher, as much as 18.5%. And the reason why there is a discrepancy in the literature, if we look really deep, is because if the case series reports on a patient with mean BMI less than 40, the recurrence rate is obviously better than when the mean BMI is more than 40. It's also possible that the higher BMI patients had wider defects, and that could also skew the interpretation. But overall, we believe that BMI 40 may be more acceptable in our cohort because in Asia, metabolic syndrome also tends to occur more in lower BMI group. So we took 40 as a cutoff, which has also been endorsed by some other papers as well. Our strategy of classifying patients also was a little different, and we modified the one which was published by Ede et al. We made it into 4 groups, and we'll tell you why a little later. We divided our patients into favorable hernia with favorable obesity, group 2, favorable hernia with unfavorable obesity, group 3, unfavorable hernia with favorable obesity, and group 4, unfavorable hernia with unfavorable obesity. Now, this may just sound a little funny and confusing, but let's look at the visuals to make it simpler, which it actually is. Now, the same patient that I showed you earlier, BMI 32, the body wall thickness, now I'm giving it away, is less than 4 centimeter in this patient. So it's a favorable obesity, and it's a 2 centimeter umbilical hernia. So through the prism of our classification, this falls into group 1, that's favorable hernia with favorable obesity. In this patient, what procedure should we recommend? Well, we know from IAGES guidelines that laparoscopic repair is recommended for BMI above 35, and open repair is going to lead to higher surgical site occurrences and infection. Therefore, our strategy has been to use IPOM plus or endoscopic reef stopa in all our obese patients, and this has worked for us. Now, let's take a look at the next group, which is in this patient, for example, the BMI was 40, the patient had an android obesity, patient has diabetes. Naturally, this patient is unfavorable obesity based on the classification that we offered. And this patient has got a same 2 centimeter umbilical hernia like the first visual. This makes it into category 2, a favorable hernia, but clearly the obesity is unfavorable. So in group 2, what do we advocate? If we look at the literature, by one paper by Bmi et al., where they looked into 30 patients who went for upfront hernia surgery, they were all obese, and there another 170 patients who went for bariatric surgery first and then went for a hernia surgery as a deferred repair. They found that the recurrence rate in the upfront hernia surgery was 3.3%. That was only 1 out of 30 cases. And most of these patients, like 20 out of 30, had a small defect, W1, less than 4 centimeters, which leads us to believe that in these hernias, small hernias, even in higher BMI patients, we can still offer them IPOM plus. And the only caveat or the rider is that we try to get them lose a little bit of weight with a medical supervision, and we use larger mesh with more crowning or more tacks or more transfacial sutures to augment our repair. And this is what we have done. This is the group 3 where there is a 12 centimeter incisional hernia, which definitely makes it into an unfavorable hernia. Incidentally, the patient also has a large pannus. But if you look at the obesity, the patient has got a BMI of 38, a gynecoid obesity, and there's no diabetes. Therefore, this patient has an unfavorable hernia. But since most of the fat is concentrated in the thigh and the hip, the patient doesn't have any evidence of metabolic syndrome. This patient has a favorable obesity. And therefore, in this patient, the question is, this patient would require a component separation technique or a reconstructive procedure, and possibly a panniculectomy as well. Is it safe to do it? Will it lead to good outcomes? If we look at this very huge paper coming from the Charles Butler group published by Giordano et al., in 511 AWRs in obese patients, the recurrence rate in both obese and non-obese were similar. And if we look at the SSO-SSI rates and medical complications, yes, these were higher in the obese. Therefore, for this patient, yes, we can offer them an open component separation technique, understanding that there will be a higher SSO-SSI and medical complication rate in this patient compared to a non-obese. And can we add panniculectomy? Well, we've been adding panniculectomy and in these favorable obesity, and so far, despite the fact that we've had a higher SSO, we have not regretted because of mesh infection or some serious deep SSI. So we are doing it. Considering the SSO and SSI is higher in this group 3 patients, we think that if there are patients who can benefit from endolaparoscopic technique, then it is probably preferable. And therefore, for example, in this patient who has a 8 centimeter hernia in the L2, non-midline, which makes it an unfavorable hernia, this patient can be offered an open surgery and an endoscopic posterior component separation. We prefer to do an endoscopic posterior component separation technique, or TAR, because we we definitely going to give this patient a lesser chance of SSO and SSI had we done it by open surgery. So now this is the group 4 patient where the BMI is high. This is an android obesity. Patient has diabetes. And if you look at the hernia, it's a 12 centimeter incisional hernia. It's irreducible. The Tanaka index is 40%. Therefore, this is unfavorable obesity and unfavorable hernia. What do we do for this patient? Now, based on the paper published by George Eade, they have recommended in these unfavorable situations to do bariatric surgery first and hernia surgery later. And we think this is the right approach because it stands to reason that these patients are going to require a much larger or complex surgery. And a complex surgery cannot be done in a complex patient. We can always make the complex patient simpler and then perform a complex surgery. If you look at the paper by Bmi et al., again, we find that if the upfront hernia surgery is done, although the recurrence rate is low or equivalent to non-obese, or after you do the bariatric surgery, if you compare these two groups, the recurrence rate remains same, but the pseudo-recurrence and seroma rates are higher when upfront surgery is done compared to patients who undergo bariatric surgery first. Therefore, we also believe that in these cases, bariatric surgery should be offered to them first and then a hernia surgery. These patients are less likely to reduce substantial weight through medical supervision alone. So to summarize, this is what we published in 2020, our case series of 50, 46 being elective patients, and in this we showed a very good outcomes, and this is what the algorithm looks like. Just to reiterate what we said through visuals, a favorable hernia with favorable obesity gets an IPOM or endoscopic Reeves stopa. A favorable hernia with unfavorable obesity still gets an IPOM plus. We may have a medical weight loss prior to the surgery, and the rider is that we use a larger mesh and more fixation. An unfavorable hernia in a favorable obesity gets an open AWR or an endoscopic AWR wherever feasible, and some paniculectomy is something that we add when it is favorable. In an unfavorable hernia with unfavorable obesity, we tend to use bariatric surgery first and then followed by the complex hernia surgery. So the take-home message from this talk is yes, obesity has an adverse outcome on ventral hernia repair, although there is no level 1 evidence to suggest all the statements regarding this. And to manage hernia and obesity together, one should start seeing this situation through the prism of favorable and unfavorable characteristics. And then perhaps we might be able to see things more clearly. We have devised our algorithm based on our experience and expertise, but all centers should try to create their own algorithm based on their expertise and the kind of patient they serve. This has been an effort on our part to simplify things, but before I leave you, I wouldn't like to leave you with the idea that this complex problem can be solved by a simple solution, because as Albert Einstein said, make everything as simple as possible, but not simpler. And this problem of ventral hernia repair in obese is definitely a complex problem. Thank you very much.
Thank you, Sarfraz. I think you really made it very, very simple for us to understand. I remember reading this algorithm before this, and it was so clear to me, and I'm sure it has been of great help to so many other people. Any comments?
Yeah, excellent talk, Sarfraz. You made it really simple and solved a lot of puzzles in many of our minds. And I'm sure this hernia and obesity are going to go ahead closer and closer in future as the obesity is increasing in India also.
Yes.
And my compliments also for putting together a wonderful program tonight in this hernia masterclass for the ventral hernia. And as I told you earlier, I am in Rajmundri and have to proceed for another meeting on site. Please excuse me. And my compliments to Meenakshi also for moderating this session. Thank you all, and I wish all the well to Ashwin and Pallavi who are yet to come. Thank you all very much.
Thank you, Mr. President. I think your autonomy was very important to get this program going. So thank you really.
Thank you.
From the bottom of my heart. Thank you.
Okay.
Thank you, President Sir. And now I will invite Pallavi and Ashwin to speak on and to tell us about the tricky situations in ventral hernia. I'm sure it's going to be very exciting. Over to you, Ashwin and Pallavi.
So, hi, good morning, good afternoon, and good evening to those who are watching us. I'm Dr. Pallavi, and we have with us Dr. Ashwin Takavelu, and we will be talking about tricky situations in hernia surgery. So, Dr. Ashwin, would you like to say a few words before we start?
Hi friends, thank you so much for this invitation, and thanks a lot to my co-host Dr. Pallavi, who did the hard work. I'm just pretty much participating and contributing in a little manner whatever I can. Over to you, Pallavi.
I'm banking on you for this entire presentation. So we will talk about some tricky situations. So hi, good morning, good afternoon, and good evening to those who are watching us. I'm Dr. Pallavi, and we have with us Dr. Ashwin Takavelu, and we will be talking about tricky situations in hernia surgery. So, Dr. Ashwin, would you like to say a few words before we start?
Hi friends, thank you so much for this invitation, and thanks a lot to my co-host Dr. Pallavi, who did the hard work. I'm just pretty much participating and contributing in a little manner whatever I can. Over to you, Pallavi.
I'm banking on you for this entire presentation. So we will talk about some tricky situations. It's good that we try to avoid them as much as possible. But all of us will run into one situation or the other at some point of time where we have to handle it as the shit comes. We can't always avoid those. And it's good to share what has already happened with us, or it's good to know what has already happened with our colleagues. So we are prepared for it when the situation so comes. I'll start with a relatively common one. How often in a minimal access hernia surgery, let it be an IPOM, let it be an ETAP, or any kind of repair, we come across this kind of a situation. We have taken down the adhesions. This was an M4 hernia, so there is a peritoneal flap along with the bladder that has been brought down. We can see the defect approximately 5-6 centimeters, and there is a divarication extending upward. So, Dr. Ashwin, how often? Often enough?
Yeah, this is quite a common scenario actually, especially in the women, mostly when we see all these primary hernias or the lower abdominal hernias. Yeah. Almost always they are associated with divarication. The amount of divarication might vary, but it's all a common trend.
So does your surgical plan change in these situations? Does it become different than what you had initially planned?
Yeah, so nowadays of late, I think more and more in my practice, we have started repairing all these significant divarications along with the repair. So we feel more comfortable in giving a good durable repair rather than just a simple defect closure, which we feel might not be good enough.
Mm-hmm. And for us also, when you see this thin a tissue here, it's really hard for us to rely on this for the edges of the repair where we are going to put tags or sutures. So first step, of course, is going to be the defect closure. And here I would like your opinion, Dr. Ashwin. So in situations like this, quite a few times we think it's relatively hard for us to get a longitudinal closure of the defect, and with IPOM port positions we think it's relatively easier for us to do a transverse defect closure. What do you do?
So generally, like you said, most of the times with the port position it depends on the ease of suturing, whether it's transverse or longitudinal, depend upon your port position. traditional like palm port position, or like say in the epigastric and right and left subcostal port position. I generally tend to err on the side of the way the defect behaves. Generally, we don't see a lot of these round defects. It will only be in these primary cases. In incisional hernias, there will always be one side which is a slightly longer compared to the other one. So based on that, we would start the suturing along the longitudinal axis of the defect orientation. So that is how we go about it.
Right. So if you're doing the defect closure, do you continue the same sutures for divarication repair as well, or these are two different steps?
Yeah, so a lot of the times, at least commonly, more than 90% of the cases, we are able to suture the defects in a longitudinal fashion, and we just continue with the same suture and repair the divarication as well. So even when we start the suturing, we don't start at the edge of the defect. We pretty much start low down from the area where we would, correct the divarication and just keep coming up cranially. And if we need another suture, we would again start with another suture from the cranial portion and then meet somewhere in between.
Right. Is it easy to suture from cranially to caudally with these port positions? How easy or difficult?
No, it becomes challenging. Like say if you're doing a knee tap RS, so we sometimes even might have to add additional ports in the lower abdomen, and we kind of orient ourselves in a different way by having a camera towards the right shoulder, and we start the suturing in the superficial and superior part of the area where the divarication is present. Certain patients we might be lucky where the divarication is predominantly lower abdomen, then we can get away with just conventional suturing. That it becomes easier.
Yeah, don't often come across with these patients, do we, where divarication is mainly lower abdominal. Supraumbilical divarications are relatively more common in these women that you talked about. So what was done in this case? This is a video from Dr. Baig. First, analyzing the complete extent of divarication. That means bringing down the falciform and assessing how far above is the divarication extending and how wide is this. You can see in this image, it was almost 5.5 centimeters. After doing the defect closure, he has taken a V-lock and he's sutured it caudally to cranially. And camera is in the middle. The needle holder is in the subxiphoid port in this one. So that is how it will happen. Again, one more question. Do you cover the entire divarication area with a mesh?
Yeah, so generally, whenever there is a significant divarication present, I generally try to go to either ETFRS as my procedure to go, or something like a TARM, and I would prefer to cover the entire area where I've sutured with a mesh, because almost always they are like coexistent with the defect. And if you look at these sheets as well, as explained to you by earlier, they're super thin. They're like papery thin, and any suture which we make, I don't think will hold on. So it's better to reinforce it with a mesh. That I think would be more sound if we want to have a durable divarication repair.
Right. So this is exactly what we do usually. And you usually use V-lock, Prolene, PDS. What do you use for closure of these defects and divarications?
So whenever it's an incisional hernia, I prefer to use a non-absorbable suture. But for divarication per se, I'm quite comfortable even using a delayed absorbable suture. The only thing is, I don't think that the suture alone is going to play a role holding the divarication in place. I think the tissue has to kind of get refashioned, and that only will hope and help in the long term. So just the suture, I don't think will hold. Even if it's a non-absorbable suture, I'm sure it'll cut through, and we might have the suture at only one edge of the divarication, not on the entire repair.
And since it's usually a relatively long area that you have to suture in one go, do you get barbed sutures for these?
Yeah, so nowadays I think I'm probably becoming a little more lazy than what I used to be, and I feel more comfortable with utilizing these advantages of the barbed sutures. The other thing is I'm a little concerned about having the barbed sutures exposed to the bowel. So here, when I stay in the retrorectal space or a preperitoneal space, I anyways have the peritoneum on the mesh behind the barbed suture. So that makes my life a little more easier, and I'm quite comfortable with that.
So yeah, I think that has been very helpful. Let's go on to the next scenario. Again, this video has been given to us by Dr. Baig. Let's see what's happening. There is a TEP going on in a patient who has had a complete inguinoscrotal sac. What normally happens in these cases, we are not able to reduce the entire sac. So we ligate the sac somewhere in the middle, divide it, and then complete the surgery. So from what we see, this is what looks like the plan. He has isolated the sac and he is ligated the sac. And the next step would be opening the sac and completing the repair. So there you go, he's opening the sac. And you can see there is some content inside. What looked like just a thick fibrosed sac has some content coming in. So I would pause here. And Dr. Ashwin, what do you do in this situation?
So generally, my preference of procedure in any patient where there's an irreducible hernia is to do a TAPP repair. So a lot of the times I don't encounter with this intra-op. Generally, my decision is made preoperatively, and I prefer to go intra-abdominal because I feel more comfortable to manipulate the contents. Having seen it, if I know it's not bowel and only momentum, then I can be a little more liberal. Whereas if it's bowel, then I'll be really careful and make sure that I don't use too much of manipulation by the instruments and everything. But if at all I have to undergo this, this commonly happens when there is the omentum. Not very common to see a bowel there because we always have a feel of how the sac looks like. So then I would probably just divide the tie and just pull up the contents a little more into the field, check for it's just omentum and there is no bowel associated, and then I would push the contents back. This would be my go-to. Because what happens is once you have dissected a large space, as you have done over here, laterally and medially, even if you have a small rent, it doesn't collapse much. And the other thing is when you pull the contents inside into the field, that kind of puts the openings present. So you don't really lose a lot of pneumo. So it's only after pushing all the contents inside, you might have a transient loss of pneumo, but that can be easily managed. You don't even have to do any maneuvers. Probably just a little head down would be good enough. Nothing else is required.
So let's see what he does in this case. He completes the reduction of the contents, and it appears he divides the sac completely without opening the ligating suture. We did have a conversation about this, and his principle behind doing this was we open the sac now. Probably pneumo can impede the surgery further on. So this allows us to make a little more space. And once we have that space, we open the suture, inspect the contents, reduce them, and take the surgery from there. But like you said, yes, if we have enough lateral and medial space developed, we probably do not need to worry about pneumo so much.
Yeah, I think immaterial of how we do it, I think this is the most important thing which probably we should give as a takeaway, that you dissect and do the parietalization completely before you go on and repairing the rent. Because you'll be surprised that once you do the parietalization, the peritoneum would actually come in very easily, and you can most often apply just a conventional endo loop. Whereas if you keep it intact, adhere to the cord structures and stuff, then you will feel like it won't come with the endo loop, and you will actually cause more damage if you keep trying to pull the edges together. So the important thing is parietalization and then, you know, repair it.
Also, what you said in the very beginning, it's probably prudent to go with a TAPP when the hernia looks large and reducible. May help us avoid these situations altogether.
Yeah, because a lot of the times, you know, I feel that we just probably making it a little more difficult for us rather than making it easier. So I always feel that if you go into TAPP, you're not really worried about what planes you are in. You're not in doubt about, you know, what type of a defect it is. The other reason why I said that is if I see bowel, and, you know, a lot of the times it's the colon which is stuck densely and it's a narrow ring, then it might even be very difficult for us to pull the contents easily inside. So then even a small hybrid kind of a incision at the inguinoscrotal region or the scrotum can be made much upfront, and the damage and injury possibility to the colon or the bowel also would be reduced a great deal. So that is what I generally follow in my practice, because a small incision in that region is not a problem at all. Whereas if we have an injury that kind of totally messes up the plan which we have for the patient, and then adds on a lot of question marks where we are not sure whether we should place a mesh or not, and if we place it, whether it will be fine or will there be an infection. So I think it's not worth taking that risk. So that is how I try to play safe in my practice.
Moving on to the next case. Let's look at this. We have gone in for a minimal access hernia repair, be it IPOM, be it ETIP. I think in this case, an ETIP is going on. I don't know whether it is TAR or right stupor. And you find a huge sac like this. How comfortable are you continuing with an entire minimal access approach in these situations?
So if it is a wide defect and I can see pretty much the entirety of the sac, I'm still quite comfortable to proceed with the minimal invasive approach, because I would take multiple Venetian blind kind of bites on the sac and kind of imbricate it inside, invert it inside, so that over a period of time that gives us a good cosmetic result, and even the seroma rates are acceptable. It's not too bad. But if it's a very narrow neck and the sac is much huge, then it's almost impossible to access the entire thing through a minimal access manner. So then probably I would do something like a hybrid. I would just make a small incision with the pneumo. So then the sac kind of outpouches through that incision. Then you can easily do a blunt dissection all around. And if there's any small use of cautery required, you can do that as well. And once you do a little bit of the dissection all around, then you can just push that portion with your finger, and from the laparoscopic instruments hold them and pull it inside, invert it, and then kind of release the peritoneal sac all around. So that is the other thing which I do generally if it's like a hybrid procedure rather than a conventional incision, which is quite liberal in a hybrid.
So what you're talking about is removing the entire sac. So sac-related complications are minimized. This thin skin on the top of the sac, are you comfortable leaving that behind?
Yeah, so almost always I leave that skin, and generally they give good results. It's initially looking a little not so great. It looks kind of puckered, and there seems to be a lot of laxity and all that. But in 3 months and 6 months, when we have a look at the patients, they are pretty much back to their normal skin tone. So I think that's the major advantage with the skin. It expands a lot as well as contracts a lot. So we're quite happy with that. We generally don't remove them.
Right. I would talk about ourselves. We are not very happy leaving this skin behind, especially since we have started working with plastic surgeons who tell us that in situations like this and long-standing sacs, usually the overlying skin has started deriving its blood supply from the sac. So they are very radical about removing this entire skin, and somehow we have picked it up along the way. So we usually end up taking this entire thinned out skin out. It can be a transverse incision, it can be a longitudinal incision. Let's see what we did in this case. This was the defect. Defect is not that big, maybe 5 or 6 centimeters, but the sac inside is huge. As I said, it was an ETIP going on. We completed the posterior repair, that is the posterior rectus sheath repair, put in the mesh, and then we went in, removed the skin and the entire sac. So that's what we usually do in these cases. And as far as the anterior suturing is concerned, we did it open. It was all in front of us. It was relatively easier for us to do, and closed it off. Next, Dr. Ashwin, this is one of your videos. Do you want to take it? I'm going to play this.
Yeah, so this is a patient in whom I think we had a primary umbilical hernia and we are trying to do a preperitoneal, a TAPP kind of a repair. And sometimes what happens is due to some previous infection or surgery, the peritoneum is super tethered and fused to the anterior abdominal wall. Then it becomes very challenging to create a pure peritoneal flap. And in this patient also, you can see as we try to progress, we are making the holes much, much bigger. So generally what we try to do is if there are like one or two holes, it doesn't matter. Once you complete the entire peritoneal flap, you can suture the holes together very easily. So here, because it was just expanding and we were not able to get into the proper plane where we would have liked to go, we decided that the fallback option would be to go into the retrorectus space. So this is one good area where we can use the retrorectus space to complete the procedure and have a durable cover for the mesh as well so that it is not exposed, because we are going to use a conventional polypropylene mesh without any special layer. So here you can see we are just incising the posterior rectus sheath and entering into the retrorectus space. So if we are doing a preperitoneal repair, I think we just have a couple of fallback options. One is probably to go into the retrorectus space,
Yeah.
or use a vital mesh. But a lot of the times, people whom I've spoken to never find it possible to completely use a vital mesh. Somehow it doesn't work as easily as we would think. So then either IPOM, or if it's a very small opening, probably just use the momentum also to kind of, suture it over there or keep it sandwiched so that no other contents enter till the peritonization occurs. So these are some of the options we have available, and here we prefer to do the entry into the retrorectus space and upgrade it into a retrorectus kind of a repair so that we can give a nice durable flap for the patient without any exposure of the mesh.
I think you, in this situation, you're still dealing with midline hernia. So
Correct.
you get that retrorectus space. If you go laterally, for example, many times in TAR, you make end up making those holes, and then as we try to suture it, what happens? It doesn't hold, and then it keeps on widening. So maybe a mental flap in these situations is a good idea without putting in any tension. You just put in the flap.
Right. And somehow for lateral hernias, the peritoneal, the vical mesh seems to work better. I don't know, probably because the flap in the midline hangs a lot, I guess, and the lateral side maybe not so much. So that could be the reason. I don't know why practically the vical mesh works better for the lateral portion compared to the midline.
Yeah, what happens, in our setups, vital mesh isn't very easily available. And these situations, we don't foresee them very often. So we are in the middle of the surgery and suddenly we need a vital mesh which cannot arrive in, let's say, less than 2 hours, and then we are waiting for that vital mesh. It has happened often enough. So,
absolutely. And I don't know about you guys, but I haven't had the opportunity to use it laparoscopically. So the mesh is quite brittle as well. So, I don't know handling laparoscopically whether the mesh would still hold on to itself or it would kind of crumble or just, unthread and stuff. So that is again something which people say might happen. And some of them I have had that situation as well.
Okay. So coming on to what I think should be our last, because we are closing in on 30 minutes, case scenario, or second last. We'll try to finish this early. So big bleeds. We are trying to keep inferior epigastric at the top, creating a plane below it, and inadvertently we have divided the inferior epigastric. And there we go, trying to hold it. Looks like a tooth forceps, but again, probably at that time, whatever you have in hand, you'll use to apply some compression. Trying to use a bipolar to control the bleed. I think it should hold on for most epigastric bleeds, right? What is your experience?
Yeah.
Bipolar work for epigastric bleeds?
Generally, vessel very clearly, bipolar works well. Almost always they would stop the bleeding. If it's just a blind and a bulk kind of an applying of bipolar, then it might not work. But like in this case, when you can see the course of the vessel clearly and not much of tissue around, then definitely bipolar works.
Yeah.
And you
so,
can.
in this situation, I think we are not able to localize it very well till now. And that is probably the reason bipolar is not very efficient here. So now we seem to, be struggling a little bit. It makes good sense to just wait for a bit, localize it first, and then do whatever maneuvers we would do to stop the bleeding, be it applying a bipolar or taking a suture. So that's what we're going to do here. Once we have cleared the field a little bit, we are seeing where the bleeding is coming from. We have localized it. So now we can use a bipolar or take a stitch. In this case, again, this is Dr. Bake's video, and he seems to be taking a suture to control this bleed. Have you ever had to take sutures for these kind of bleeds?
No, luckily, touch wood, so far I haven't had the necessity to do it. Because in this area, I'm quite careful, and I try to see if I can see the planes well. So I generally don't use a tunic or a ligation. That also use the reason. I think the problem is when we use all these sophisticated energy devices, we are comfortable to keep dissecting with a single hand. So the hand on the assistant side probably becomes a little common to our liking. So here, probably if we give a little more stretch on the tissue, then maybe we could have tried to avoid this. So that is what I feel.
So one more. This is your video, Dr. Ashwin. You want to tell us what's going on here?
So this was an elderly lady who was diagnosed with acute calculus cholecystitis. She had an upper abdomen surgery, probably a gastric outlet obstruction or something benign piece earlier, much earlier. And so we just went through the Palmas point, and this is a colleague of mine who's doing the adduciolysis right now. And you can see actually the loop in the front is totally fine, but the loop at the back, it has got injured and it has actually opened up. So even though we had good bowel graspers with us, sometimes these bowels are edematous and super friable. So the lesson is we generally try to avoid holding the bowel whatsoever, and we try to either use the fibrous tissue around or the mesentery to hold. Because in the mesentery, a lot of the times, if it's small bowel, it's just a bleed which can occur, and you can easily coagulate it with a bipolar because the vascularity of the small bowel is pretty good. Unless it's at the root, we should not really be bothered about the problems it might cause at all. So that is something which we have to be very, very careful, because small bowel as additions in our ventral hernia surgeries is very, very common.
And if this happened during a ventral hernia surgery, would you, with this big an enterotomy, would you still proceed with putting in a mesh?
No, I generally don't. See, even in this case, if you actually have a look at it, we didn't even have a single drop of bile coming out into the field. But since we've opened the bowel over there, and it's quite large, it's not a small, puncture kind of a hole which is present. So I wouldn't really put in a mesh. I would just do an anatomical repair, come out, explain, and probably go in a little later.
Right. And of course, you were lucky enough to see it happening intraoperatively and repair it then and there. We have had a situation like this on post-operative day 2. This was a patient with a large lumbar hernia. After Botox and a peritoneal flap and component separation, the defect could still not be closed. So there was a bridging repair done. Posterior layer was bridged with a vitral mesh, and anteriorly there was a polypropylene mesh. We see this bile coming out. So what next? Go in immediately?
Yeah, I mean, once you see this, it's small bowel. There is no other alternative option. So generally, I would still see if any scope for laparoscopy would be there as a diagnostic tool, because if there is not much of distension, I still would like to do a diagnostic lap. A lot of the times they will be like, small puncture holes. If it's an obvious lesion, especially in the open surgery, we would have picked it on the table. So it'll be like a small puncture or a cautery kind of a transmitted one. But this you said 2 days, so probably it's just a small puncture hole would have occurred. And we can easily identify them when we do a diagnostic laparoscopy and just scan through the bowel. And if we can identify them and suture it, that's the best, because you can reduce the wound morbidity a great deal for these patients. But then again, we have to take a huge call on what we're going to do about the mesh, because that's the other challenge which we'll face.
So yeah, this patient already had an open repair. There was already a big incision there. Second, there was some abdominal distension already happening. So we decided to just open through the incision and go in. You can see in these pictures, there was a hole in the small bowel indeed, and bile was coming out through it. So what we did in this situation, we repaired the hole, put the bowel back in. A posterior layer bridging was done with a vicryl mesh, and we applied a negative pressure wound device. Left the anterior layer open, did not close it. And as you can see, anyway, the anterior layer layers are so far apart, it would have been almost impossible to close this. The only option is bridging with a mesh, and you don't want to put in a mesh in this situation. Do you close the skin? Do you not close the skin? Again, that is a dilemma. So we went ahead with a negative pressure wound dressing, and once it was comfortable enough, we just closed the skin without closing the sheath. We closed the sheath as much as we could on the sides, but in the middle, yes, there was a huge gap. And this patient is supposed to come in later on for a definitive repair of a hernia. Dr. Ashwin, are you there?
Yeah, I can hear you, Pallavi.
Yeah. So I think that concludes our last scenario. And anything you want to add to this case? Anything we could have done differently? Anything you would have done differently?
So in this patient, I don't think we could have done anything, because even if we could have closed the anterior sheath, definitely she would have developed an abdominal compartment syndrome kind of a scenario. So we would have had to do some form of a laparoscopy, and what you guys did was probably the best option available right now.
And do you routinely use these negative pressure devices in situations like infection, or when you have to leave an open abdomen for an emergency situation?
Yeah, not as much as I would like, because a lot of the times the financial implications becomes a huge problem. But nowadays it is becoming a little more cost effective, and we're getting more, players in the market, and it becoming a little more easier. So probably next time when we have a discussion like this, I might have a totally different answer for you. But right now it's still quite low, not a lot. I would have definitely loved to use it a lot more than what is being used right now.
Right. So thank you so much, and we look forward to any suggestions, any questions, any discussions that happen from now on. Thank you very much.
Thanks a lot, Pallavi, for that wonderful session. So happy to always be participating, and nice to see you also.
So thank you, Pallavi and Ashwin. We have a question for you from Dr. Hemendra Sharma. In case of irreducible inguinal hernia done by TAPP, where the content is omentum and the omentum has been reduced by omentectomy, and if some pieces of omentum remain adherent to the scrotum, which are found after the surgery in the OPD, like the patient comes back with a complaint of some contents, what are the options in such a scenario?
So I think the vascularity of the omentum would be the key. So if the patient is doing well without any signs of, say, toxicity or anything like that, then probably a little bit of vascularity is still coming from the attached portion to the peritoneal sac. But this scenario is not very common in a large inguinal hernia, because they generally have a pretty wide neck, and we can easily see the contents up to the root of the scrotum. So most often they are addressed during the surgery itself.
And one suggestion from me is again the hybrid approach. Suppose there is a large amount of omentum in the scrotum, you can just give a small incision in the scrotum and remove that separately, because otherwise the patient is very likely to come in with this complaint. And so the job has to be completed right then and there. A small incision on the scrotum doesn't matter.
Absolutely. If we know that there is some momentum, it has to come out. There is no two ways about it.
Any comments?
Dr. Safras, we are not able to hear you.
I think it was a wonderful session and a very nice camaraderie by both Ashwin and Pallavi. Very, good educational points shown with the videos. So really enjoyed it. Kudos to you.
Can you hear me now?
Yes, sir. Fine.
Okay. So thank you, Vivek. Thank you, Meenakshi. Thank you, Pallavi. Thank you, Ashwin. Thank you, Vandana. And everybody who stayed behind. And I think it's been 3 hours and we've been at it. And this has been a wonderful session. Everybody's contributed so well. I think this recording is going to be there on the YouTube and the Facebook. So from the archives, you can always revisit this. I think there were some wonderful messages throughout the session. I don't see Dr. Ramesh Agarwal and Dr. Sunil Popet and Dr. John Thanakumar, but I'll take the opportunity to thank them as well. And Meenakshi, you want to conclude this because you are the chair of the session?
So my main conclusion right now is going to be a big thanks to you for making this happen, a wonderful masterclass. Dr. Sunil Popet had to leave because he is traveling back from Rajahmundry. Yes. And the main thanks also comes from him. Thank you very much.
Thank you, everybody. Have a great evening, whatever is left of it. Thank you.
Thank you.
Enjoy the session. Bye.
Yeah, signing off. Thank you, Medinit.
Thank you.
Thank you. People have now.
Bye.
Yeah. Bye.